Thank you for joining us for session 4 of the ASPN virtual think tank. Tonight we are talking about peripheral nerve stimulation and RF ablation. We will give everybody 2 minutes time to log on, and then we will begin the program. Thank you everybody for logging on to the webinar tonight. We are going to give everybody 2 minutes to log on, and then we will begin the program.
I'm Dr. Tim Deere.
And I'm Dr. Dawood Sayed. And we're excited to be hosting the American Society of Pain and Neuroscience's annual virtual conference, broadcast live from Nashville, Tennessee on September 18th through the 20th.
As we come together in Nashville, we'll be addressing several issues that are important to our members and to future members. Things such as minimally invasive procedures for the spine, proper methods of patient selection for interventional pain techniques, and most importantly, safety and efficacy of patients going forward as we progress the field to make things less invasive, more cost-effective, and get better outcomes.
And we want you to join us in what will promise to be the marquee event of the year in the field of pain and neuroscience. Register now to join us.
Thank you all again for joining us. We will begin with Dr. Dawood Sayed and Dr. Timothy Deere as our moderators.
Well, thank you, Stephanie, and thanks everyone for tuning in. We have over 500 people tonight who will be joining us either live or on our recorded content. So for the think tank, we're quite just really happy to see that type of partnership with everyone. Hopefully it'll be valuable to you. And Dawood, you want to talk a little bit about what they're going to see tonight?
Yeah, thanks, Tim. And we have a really great agenda. Again, we've reached already several thousand people with this think tank series over the last, this will be our 4th session with one more session tomorrow. Today, we're going to take it out into the periphery, as I like to call it. So we're going to be talking about peripheral nerve stimulation and radiofrequency ablation with a lot of, established and some innovative new companies, as well as having some really great think tank sessions. So we're going to jump into it. We have a big, lofty agenda today, and we're going to jump into our first session with SPR Sprint, first line PNS for back and beyond. We have 3 really fantastic faculty, Amit Gulati, Mehul Desai, and Shalini Shah. We're going to start with Dr. I believe Desai.
All righty, next slide. All right, my name is Shalini Shah. We're going to start talking about Sprint. And to put the technology in context, I kind of want to talk about where we were and where we're going now. Historically, peripheral nerve stimulation was kind of considered the last resort, required surgery and implantation. There's also a whole host of risk factors that were involved with it. And where we are now is that you can have essentially just a needle puncture and deliver the same type of energy to the nerve that previously required surgery. So in my opinion, really, now we're putting peripheral nerve stimulation technology at the forefront as an earlier option for patients rather than a last resort. So next slide, please. In the words of Peter Staats, this is a game changer, and I couldn't have found better words to say it myself. It really is a game changer in terms of where we're headed with dosing energy for the nerve in a minimally invasive way. Next slide, please. So I want to focus on the outcomes of Sprint. Just so you know, Sprint is possibly it is the most extensively studied peripheral nerve stimulation system out there. And they have about 30 clinical trials over multiple sites, as well as $30 million in DoD funding. One of the most extensive outcomes that I think that everyone in this audience should know about is that 75% of patients will have sustained pain relief. And what is significant pain relief? It's defined by at least 50%. 75% of patients also had sustained pain relief, meaning at the 12-month mark, 75% of those patients who received Sprint technology still had durable pain relief, and that is phenomenal. Phenomenal outcomes. I'm going to point to the safety profile later on in the slide deck, but I just want to let you know that all of this data is publicly available on sprintpns.com and for a host of etiological factors. So whether it's back pain, knee pain, nerve trauma pain, the data is all there. So as you see on the slide deck now, you see the electrode and the system. That electrode is not much different than a peripheral nerve catheter, except that it's tiny. It is the longest electrode that's available with the shortest coil length, a coil diameter. So you have significant sustained pain relief. I also want to highlight the fact that, you know, there's a misnomer when you use a nerve stimulating device that this is a trial. This is not a trial. What we are doing is delivering energy for 60 days to the patient. So that's how you have to look at it. That this is a treatment and not a trial. So next slide, please. Great. So this is the electrode as we're talking about. It is much thinner than if you are familiar with a peripheral nerve catheter that you use for regional anesthesia. It is much thinner. It's a longer electrode and much thinner than what you would find or what you're accustomed to. I do want to point out that this coil feature that you see, it's an open coil system. So what that means is that fibrosis can occur. And so that allows to minimize the electrode moving or migrating, which is a great feature. And it also minimizes contaminants entering the area, so minimizes your risk for infection. Next slide, please. This is one of my favorite slides in terms of adverse event reporting. The biggest risk factor, the biggest side effect was typically irritation at the injection site or the electrode site. And I think that from my experience, it's possibly more likely due to the tegaderm or the occlusive dressing rather than the device itself. But I want to point your eyes down as we come down to the gray bar, infection. Guys, this is an N of 410 patients. And the infection rate is 0.0%. So you know that you are putting in a device that can deliver energy for sustained relief for up to 12 months with essentially a 0% infection rate. That's impressive. So with that, I'm going to move on and pass it over to Dr. Desai.
Well, thank you very much, Dr. Shah, and thank you for having me here. It's really a privilege to talk about peripheral nerve stimulation in this context. I'm here in Washington, D.C., always the most popular city in America, but it's been a privilege to participate in a whole series of these studies that have looked at the effect of Sprint's peripheral nerve stimulation device in a variety of clinical scenarios. I'm specifically going to talk about PNS and chronic low back pain, which has been a really exciting development both in our practice, but also from a research perspective. As Dr. Shah talked about, previous studies have shown that percutaneous peripheral nerve stimulation provides long-term clinical and statistically significant reductions, both in a variety of disease states, but specifically in chronic shoulder pain, post-amputation pain, and in a prior study looking at feasibility in chronic low back pain. In that study that was published by Dr. Gilmore in the paper you see here, they talked about highly clinically significant reductions in pain intensity of greater than or equal to 50%, which were sustained long-term. So that 80% of subjects at 3 months post end of therapy, so 4 out of 5 subjects had greater than 50% reduction. And even at 12 months, 50% of subjects, 3 out of 6, continued to have that level of relief. So you have, as you see here on the chart or the graph, 63% had an average reduction, or 63% was the average reduction amongst responders. So, and what was interesting about this is that the responses persisted in many cases even well beyond the 12-month study duration. So it's a really exciting potential, or the exciting possibility of providing 60 days of therapy for a patient and realizing more than a year of benefit. And in some cases, we're approaching 2 years of benefit in many patients. There's been a history of publication, as Dr. Shah talked about, and way back in 2005, in what seems like a long time ago now, John Che published in the American Journal of PM&R in these chronic shoulder patients, and Dr. Rosnow published in neurosurgery in these post-amputation pain patients. So there's been a series of publications that have led up to looking at this therapy in the low back pain population. And as most of us know, this is a population that we're very eager to be able to treat. And the beauty of this therapy is that it allows us to position a treatment for these patients at a place where we historically didn't really have options. And we're able to position a therapy temporarily that may allow many of these patients to get better long-term without having to undergo other more advanced procedures. And it's sort of shifting the paradigm in terms of where we consider this treatment. Can we go to the next slide, please? We talked a little about pain. We also looked at a subgroup of these patients with regards to their opioid use. So not only were we able to look at opioid use, but pain and disability scores as well. And with peripheral nerve stimulation of the medial branch to treat low back pain, we saw that at 3 months post end of therapy, 73% or 8 out of 11 subjects reported greater than 50% reduction in opioid consumption. It seems like a pretty meaningful response in those patients. Now, admittedly, that's a small subgroup, and we're hoping to see what the larger multi-center trial shows. But we've now completed that multi-center trial, I think, with 100 subjects in it. So hopefully, this signal will persist in that group of subjects as well. On average, there was a 23.1 morphine milliequivalent reduction amongst responders. In addition to that, we were able to see significant reductions in pain, ODI, and pain interference. You can see on these charts that these subjects, so 64% of subjects had greater than 50% reduction of pain, and there was an average reduction of 70% amongst responders. With ODI, 82% of subjects had a greater than 10-point reduction in their ODI, with an average 26-point reduction amongst responders. And with pain interference, 82% had greater than 30% reduction, with an average of 69% reduction amongst responders. So really across the full spectrum of treating low back pain, a really positive response and a signal that really portends well for future studies and for the kinds of outcomes we're able to achieve, again, with a really truncated short-term treatment window, resulting in these really exceptional long-term results. Can we go to the next slide, please? So treatment delivery itself. So what you have here is placement of a 300 micrometer diameter lead, and it's percutaneously placed under image guidance. So in our practice, this can be either ultrasound or fluoroscopically placed. We tend to use both techniques simultaneously so that we fluoroscopically locate the location that we're going to target, and then we use ultrasound to confirm placement by confirming multifidi activation. And what you have here is you target the area bilaterally in the center of the most painful region. Pretty simple, straightforward placement. It usually takes a minute or so per side to place this. And I think Dr. Gulati may talk about this a little bit, but if not, there's a lot of studies that have shown that over time, patients with non-specific chronic low back pain develop atrophy and fatty infiltration at their multifidi. So there's a lot of interest and excitement around treating this area. And again, this allows us to treat this in such a targeted fashion. The peripheral nerve stimulation treatment itself is delivered 6 to 12 hours per day for up to 60 days. The treatment induces a cycling tension within the multifidi at 50% duty cycle. And participants are able to continue normal activities during treatment. And at the end of the treatment period, the leads are removed via gentle traction. It's a really simple removal that doesn't require any image guidance to do so. Next slide, please. So some subtle differences in terms of targeting the medial branch. So when we ablate medial branch nerves adjacent to the facet joint, the technique has always been taught that we want to be parallel to the nerve. That's a big part of the consensus guidelines that came out earlier this year with regards to appropriate placement of the radiofrequency probe and the subsequent, the needle and the subsequent probe. In comparison to peripheral nerve stimulation with SPR, we're stimulating the medial branch nerve inferior and medial to the facet joint. And it's a very straightforward perpendicular placement to the skin. So really there's not a lot of extra skin or a lot of extra tissues that are traversed in order to place this needle. So really, in my practice, we align the end plate, and we're going to look at a couple more slides. If we can go to the next slide, that'd be great, where we can see exactly where we want to place the needle. So you can see in this slide that the yellow hashed line is an example of the pathway of the medial branch. So as opposed to radiofrequency ablation, where you would place the needle sort of at the junction of the superior articular process and the transverse process, or slightly higher up on the superior articular process. Here, what you're doing is placing the needle and the subsequent lead once the medial branch is passed beyond the pedicle, just medial to the pedicle and inferior to the pedicle. So it's a pretty, and you can see here that the end plate is aligned. So it's a really simple to bony contact placement, and then we ask people to withdraw the needle slightly from bony contact so that the electrode tip is actually in the muscle or along the nerve as opposed to buried up against the bone. You can go to the next slide, please. So here you can see successful stimulation of the medial branch is best confirmed, and here you have an ultrasound view of multifidi activation, and so it's a very clear view if you decide to use this technique. What I do in my practice is I find the midline and I find the spinous process and I slide over to the multifidi, and when the duty cycle comes on, which during testing mode is on for 1 second, you can see a very clear contraction of the multifidi. And you can see this intermittent tightening and relaxing of the muscle, and you really want to see selective activation of the multifidi. If you're seeing erector spinae, you may be too lateral, or you may not be deep enough. So you want to be cautious of that. And if you see only erector spinae, you want to reposition your needle and your electrode. Next slide, please. So when it comes to patient selection in these patients, we want to make sure we've ruled out fracture, infection, any major instability, probably more than 3 to 5 millimeters of a spondylolisthesis or more than a grade 1 spondy, cancer, and any other things that might be real risk factors for lack of efficacy. Pain should be confirmed to the low back without significant radicular pain. Referred pain is different, but radicular pain we want to avoid. And then most of these patients have a mechanical or non-specific low back pain pattern, and some have failed prior RFA or have experienced recurrence of pain following their RFA. In general, we advise that people wait about 6 months after radiofrequency ablation to allow the medial branch to regenerate, although that's a general rule, not very specific in terms of guidance. So how does peripheral treatment of low back pain with SPR and with Sprint change the pathway to chronic pain? So what we know is that in general, we propose that this may induce reconditioning of the central nervous system. What we know is that there's an inciting event that changes neural signaling with increased abnormal and spontaneous afferent signaling, pain that then endures even after normal tissue healing. This leads to regional and central sensitization, where you have changes in central pain processing and hypersensitivity to normal inputs. Then you get this maladaptive cortical plasticity with unbalanced sensory inputs, which lead to cortical remapping and an imbalance in nociceptive processing. What Sprint and PNS do within 60 days is to help improve neural signaling by increasing healthy afferent signals in non-pain nerve fibers, which then may modulate sensitization by modulating the central pain processing, but also reducing hypersensitivity to normal inputs. And then this allows there to be reconditioning of cortical processing and rebalancing of sensory inputs to restore healthy cortical processing of nociceptive signals. Next slide. So why we think that Sprint's PNS system might be a first-line treatment is because it allows us to non-invasively, non-destructively treat, in this case, chronic low back pain. In my practice, this is really, and maybe this is a bit of a statement that some people might have issue with, but it's really we're starting to evaluate whether this, particularly in younger patients, needs to replace radiofrequency ablation, or how it should be positioned against radiofrequency ablation in our patients, at least, because it's not a destructive therapy. The other advantages are that it's a larger monopolar electrode that doesn't have to be immediately adjacent to the nerve in order to provide stimulation to the nerve. It can be up to 3 centimeters remote and still be successful in providing those or stimulating those nerve targets. Stimulating efferent fibers physiologically activates afferent fibers, which is another advantage. And focal and robust signals may reverse maladaptive changes and promote long-term pain relief even after lead removal. And again, we're seeing this up to 2 years out after this procedure. So thank you, and I'll pass it on to my colleague, Dr. Gulati.
Thank you, Mehul and Shalini. That's a wonderful presentation so far of a really exciting technology. And when I started thinking about this particular technology, the real question was, we have a device that's doing something different than some of our pain procedures have really been doing before. Thinking about the multifidus muscle specifically and targeting the medial branch nerve, here we have an opportunity to say, are we doing the right thing in terms of order of progression? When someone comes in with low back pain without radiculopathy, images don't show something significantly that needs to be resected by a surgeon. We typically think about physical therapy, pain medications, and maybe some simple injections, let's say muscle injections such as a trigger point, medial branch nerve blocks. But then the real question becomes, what do we do next? And when I was training, obviously the solution was, why don't we ablate the medial branch nerve? Now, from a physical therapy standpoint, from a physiology standpoint, some of the decision that a therapist makes is really to activate a muscle that's not working properly. And in this particular case, the recti spinae musculature, such as the multifidus muscle, which is that muscle is a part of. And perhaps we can think about this a little bit differently. Perhaps instead of ablating a nerve that may infect a muscle adversely, why not stimulate that muscle for 2 months, something a physical therapist is trying to do with core strengthening, and see if that has the same effect or an improved effect in pain relief. So it's interesting to think about the strategy that may be involved in choosing one paradigm versus another. Next slide, please. So what's interesting is we have an industry partner that has really thought about how can we determine what a patient would prefer when choosing these modalities. This is something that physicians do when they have talking to their patients and suggesting, such as a spinal cord stimulator or an intrathecal pump for refractory back pain that's from failed back pain syndrome. And perhaps we give pros and cons in oncology for those reasons. But it's interesting to think about doing an actual survey-based study in this population that otherwise would have a choice between temporary peripheral nerve stimulation and radiofrequency ablation. So the first attempt of this was to ask patients, potential patients, a certain question: if you have back pain and you are an option for 3 treatment options for your axial back pain without radiculopathy, a traditional radiofrequency ablation and that procedure described to that person, a temporary peripheral nerve stimulation, or a permanent implant device such as a spinal cord stimulator or intrathecal pump. What you see in this subgroup of the analysis of 3 different complex pain syndromes, what you see is of 96 patients, most people would probably not choose a permanent implant first, which is for very logical reasons. People like to have a treatment that is done and their pain relief is improved without having a device implanted. This happens even in oncology. But then you see a reasonable split between temporary peripheral nerve stimulation. There's slightly more patients responded to that therapy as opposed to radiofrequency ablation. Next slide, please. But to take this one step further, we have to talk about temporary peripheral nerve stimulation and its side effects, radiofrequency ablation and its side effects, and then the choice of not having either procedure and staying with some of the conservative measures that we have available. And so one of the things that was done in this particular survey was to work with a group of physicians who are ethicists and really thought about which words to use when presenting different modalities to these patients. So when you present a peripheral nerve stimulation, the appropriate words that would suggest the effects and the outcomes of peripheral nerve stimulation, but also the side effects. In this particular case, Dr. Shah mentioned the infection rates are very low, but one of the concerns that we have with the device is the possibility of the fracture. Though it's a very low rate, it's still a possibility for patients and things to be concerned about. So that was one of the additions to this particular survey question to the participants. And for radiofrequency ablation, one of the potential side effects is the ablation of tissue that's around the nerve, not just the medial branch nerve, but also the musculature around the nerve, and the possibility of denervation of that muscle, and what's the possibility of long-term side effects as a result of that. When you give the patients a choice of both positive outcome and possibility of side effect, what you found was temporary peripheral nerve stimulation was still the preferred method of treatment for low back pain. However, there are a significant number of patients that would choose neither. This is at roughly almost 80 or 90 patients would choose neither. 80 or 90 patients would choose radiofrequency ablation, and about 160 or so patients would choose temporary peripheral nerve stimulation. So the idea of putting something in your back for 2 months that likely will come out without a fracture seemed to be preferable to radiofrequency ablation when we think about the fact of the possible loss of function of the multifidus muscle. What's the most important here with these questions? Again, they were done and written by an ethicist, really thought about the appropriate words. So there was no, to lower and as much possibility of there being bias in the words that we use to connote the outcomes in these particular modalities. Next slide, please. So while we've talked about the therapies that you can have for low back pain, specifically peripheral nerve stimulation versus radiofrequency ablation, which is by far the standard of care for interventional pain physicians, what we find is that in the last couple of years, we've had some multi-specialty working groups. Steve Cohen and Anuj Bhatti have led some practice guidelines in radiofrequency ablation. One of the things that we can probably expect when we do ablate the medial branch nerve is we can expect some paraspinal muscle degeneration and even possibly disc degeneration with that procedure. It is something important to discuss with your patients, the consideration that you might have this effect on the muscle, and therefore that's why we recommend physical therapy as a first-line treatment for low back pain and other motor-sparing options, even before radiofrequency ablation. And the important statement here is that perhaps peripheral nerve stimulation from a temporary modality may be a good option between an injection and considering radiofrequency ablation. Next slide, please. So what we want to look at is, do we have any kind of data to suggest that ablating the medial branch nerve does lead to injury to the lumbar paraspinal muscles? And so this is some of our radiology colleagues presenting some data about what happens to the multifidus muscle under imaging of the MRI, using the MRI as an imaging modality when you have radiofrequency ablation of the medial branch nerve. What you see is that if you had a positive response to the RFA, they would see these patients 24 weeks after their procedure, and they would evaluate their multifidi musculature. And what you see is that there's an increased fatty infiltration that's statistically significant at 24 weeks to patients that don't, to the patients before they had the radiofrequency ablation, and we have some multifidus atrophy associated with that as well. Now, it can be more conjecture about thinking, what does this truly mean clinically? But from an intuitive or theoretical standpoint, losing the function of an important muscle that is part of your core strength is countering what a physical therapist is trying to do, which is to increase the strength of that muscle. So we really want to think about where would patients be adversely affected by the ablation of this muscle, especially in low back pain patients, when we're comparing the two modalities, peripheral nerve stimulation and radiofrequency ablation. Next slide, please. And part of this is thinking about what we're actually doing when you place a needle in the muscle and trying to ablate the medial branch nerve. Can we go to the last slide, please? What I'm trying to illustrate here, what we're trying to illustrate here is, if you think of the slide before this one too, what we think about in this particular population, one slide back, is that we're using a very long radiofrequency needle. On the middle of there is the standard RF needle probe, which is showing you the ablative potential of a radiofrequency nerve. Next to it is a cooled RF probe, which is commonly used for some of our ablative procedures. What's important to realize is that the medial branch nerve is a diameter of 1 millimeter at best. And it's the ablation area of a radiofrequency needle is in the order of 4 to 6 millimeters in length in width, and up to 1 centimeter or 10 millimeters in length. So one of our techniques to target the medial branch nerve is shown in this slide on the left. So this is some of the work we've done on the swine model. This is an animal model for ablating the medial branch nerve. So one of the techniques that we are studying or have studied over the years is using high intensity focused ultrasound, which is energizing the tissue to thermally ablate tissue, and specifically the medial branch nerve. What we see in that particular slide is that when we use one sonification of a HIFU lesion, the volume of that lesion is roughly between 20 and 35 millimeters cubed. That's roughly 1/10 of what the radiofrequency probes can do. So if you look at what we do in the swine model, which is roughly half the size of a human spine, we're ablating the target, which is really at the corner of the transverse process and the superior articular process. We're ablating that consistently with our needles, but we're leaving significant amount of tissue that's being damaged that's not needed to be damaged with our radiofrequency probe. So shown here is the fact that the musculature is completely ablated. It's scarred in the live pig model. This is pathology slides after live pig was ablated with one sonification, one lesion that's roughly 30 millimeters squared. And on the right, you look at the fact that the needles that we're using is 10 times or greater ablative potential volumetrically when you're trying to ablate a small medial branch nerve. And so when you think about the tissue damage, it's fairly significant for our patient population. Now we can go to the next slide. So what we really want to think about when we offer these patients is, let's give these patients a choice. Now, it's interesting that we think about giving a choice in the medial for low back pain and in the medial branch nerve when the standard of care is radiofrequency ablation, probably for this patient population. But in a field such as oncology, where ablation of nerves is commonplace, so something that I do regularly for the treatment of pain and at the end of life, I've transitioned to offering a peripheral nerve stimulation for 2 months of treatment to see if their patient's pain will improve without having to ablate a peripheral nerve. So if that concept is coming into oncology even, think about what a patient may choose when you give 2 different options of treatment for a similar pain problem. One of the reasons I think peripheral nerve stimulation perhaps should be considered first line in this patient population is that if for whatever reason there are patients that are not going to benefit long term in this patient population, even the data that we have presented earlier by Dr. Desai illustrates that. But in the end, ablation of that medial branch nerve is still a therapeutic option, whereas the other way around may not be a therapeutic option. So you can think about preserving the musculature, preserving the neuroanatomy prior to ablating, something that we've not thought about doing in oncology. Now we're bringing that idea back into chronic pain medicine before we get to permanent implants and surgical outcomes. We have something really novel to give some of our patients prior to considering an ablative procedure. Next slide, please. So again, as to recapitulate the things that Dr. Shah and Dr. Desai have already stated, this is a non-opioid treatment. The idea of motor sparing, preserving the multifidus muscle and some of the other muscles that are innervated by the medial branch nerve can be somewhat valuable to our patient population. There are some evidence in some of the studies in phantom limb pain, for example, seeing there's some central and peripheral spinal cord and effects that are occurring because of stimulation. And I think these are being delineated by some of our colleagues across the world, and understanding how constant peripheral nerve stimulation may affect some of these pathways. It is because it is a treatment algorithm that may involve treatment for 2 months. You can perhaps consider this as a first-line treatment for peripheral nerve stimulation when considering all of these different systems available to us today. And we have good evidence in certain pain populations that we get some durable pain relief, even with the use of a device for 2 months of treatment in this patient population. With that, I'm going to give it back to Dr. Deer and Dr. Sayed, and we'll have a nice little chat about what we've been talking about the last 30 minutes.
Great job, all of you. So if we could have our other two colleagues back with us as well. We just had a few questions for you. We want to make sure we clarify everything. One of my first question is for Dr. Shah, actually. So Dr. Shah, you said something I agree with, but I want to see if there's a caveat to it. And that is, you said that the Sprint system is not a trial, it's a treatment, which I totally agree with. In fact, we have a lot of folks who get better, and they get, after a year or two of a severe peripheral nerve injury, I've seen people get back to normal when we remove the device. So, and I'd say 7 out of 10 people based on the studies have that experience. But if they do get better and then it doesn't last, can we use this as a trial for a PNS permanent system, or would you recommend repeating the trial?
So you can repeat it again, and that's actually covered. So you can place it twice on the same patient. And if that doesn't work, if they don't have, it's still refractory to that second trial, second treatment, then you can go into a more permanent option.
And is there a time between the two that you would wait to do it again?
You mean doing the second treatment?
Well, let's say we had a patient, I had this happen recently, he had a severe median nerve injury. And so we tried, my thought was try this, see if they do well. And then if not, think about dorsal ganglion stimulation, which is off-label in the United States for those watching in the United States. But so if you do that trial and they get much better, if you do that treatment, and then you take it out, and then 3 weeks later it comes back. Now, a lot of people, it doesn't come back, as you know, which is amazing to me. Can you repeat another dose or another treatment then, or do you need to wait a while?
That's a great question. I'm not exactly sure. I would anticipate that you have to wait a year or 6 months to a year, but I'll double check on that. Don't quote me on that. But I think there's a prolonged period of time. Does anyone else know, Dr. Gulati, Dr. Desai, how long you have to wait until you can repeat it again?
The only thing I could add to that is there might be some insurance requirements that require you to wait a certain amount of time. But other than that, I think ideally, if you had benefit, I think if you could limit the amount of time that you had to wait in between, it makes scientific sense to me. But I don't know if Dr. Gulati has any comments on that as well.
I believe there's a code restriction on how many times you can use 64555 throughout the year. I don't think there's any time restriction. I will make one comment regarding using a device and as a trial, then for another device. All these devices are very unique and very special in this space. But the fields that they generate are very different from each other. A lot of it depends on the coil diameter, the length of the coil, the exact waveform that every industry sponsor uses. They're very different from each other. And then even if you choose the same exact settings from one to another, you're not going to get the same effect and the same field. And that's going to have a very different effect on a nerve. So I think when you look at the Sprint PNS system, you're really looking at a very unique device for treatment. And it may not necessarily translate to implanting another device. What I do see useful in my population, at least, is that when patients are considering between a device for 2 months that may come out and help versus another device, I found that patients in the oncology population, at least, are amenable to choosing a device that can be removed, especially since some of my patients are going to end-of-life situations. So that's something that you may want to think about when deciding to implement a device. But when it comes to comparing one to another, they're not synonymous. They do different fields and will have different effects.
Oh, great answer. Dawood, do you have the next question?
Yeah, I have a question, and I think this is probably more appropriate for Shalini as well, since that was part of her presentation. You quoted an infection rate that was astronomically low, almost nil. And when I was first presented this product, a couple of years ago, and they told me I was going to be in place for 60 days, I said, that sounds absolutely insane. If someone told me to keep a spinal cord stimulator lead in for 60 days, or even a traditional peripheral nerve lead in for 60 days, I would say the infection rate would be 100%. So what's the explanation for how, again, and I would say my experience so far has been the same. I've had really no infections with this. What is the explanation that the infection rate remains so low with this particular platform?
My guess is that it goes down to that unique coil that they have. It is a coil that's an open face coil that allows, like I said, for that fibrosis to occur, and it also prevents from the contaminants to entering the area. That's what I would say. I mean, I'm also as shocked as you are that national data is 0% despite the operator, right? Or despite the medical center that's doing this. I don't have a great answer for it, except that it must be something that's unique to the device itself, and most likely the coil.
I think that's a great answer, Shalini. I think the way it pistons like that potentially is the reasoning, and I'm with you. I was really surprised by that as well, and I actually was a skeptic initially because of that issue. I was worried I'd have infections, and so I had to become a believer. So great answer. Mehul, I have a question for you, and if you look back to our original PNS study that led to an FDA approval in 2013, a randomized prospective study, we used nerve stimulators. We didn't have ultrasound skills, so in that study, everyone used a nerve stimulator, and it got FDA approval for PNS, but we didn't truly have the outcome we get today, which about 30% of the people having a really great response in that study versus 11% with placebo. My question for you is this: maybe I think we were too close to the nerve. When we use a nerve stimulator, we were right on top of the nerve. Do you think what's our distance from the nerve with this device, and how far do you recommend that we be from the nerve when we place this device?
Yeah, that's a great question. I think to answer that, it's a twofold response. I do think that there may have been an issue with being overly proximate to the nerve, where by being overly proximate, you were getting sort of an overstimulation pattern as opposed to the kind of stimulation that this device is able to provide. So I think that makes a lot of sense, and I think that's borne out in some of the other work that's been done in some of the peripheral applications outside of the low back. I think in this case, I think we try to advise people to be about 1 centimeter or so away. I think that's the optimal distance. Certainly you can be a little bit further or closer if need be, but the centimeter seems about right, and it allows you to have the flexibility to get at the nerve without the risk of maybe overstimulating the nerve and being right on top of it. And I think the positioning and the way that the placement has been optimized allows us to get that distance without really overshooting or undershooting, and because you're working against a bony backstop, it's a pretty straightforward placement. You're sort of going right down the barrel and not having to do a lot of finagling like you sometimes have to do with radiofrequency ablation, for example. And
great.
A lot of us have that radiofrequency paradigm in mind, and it requires a little shift in order to do this procedure, but it's not a big shift. So.
No, great answer. Dawood, would you get the last question of this session?
Yeah, I wasn't going to let Dr. Gulati get off the hook, as when he was my attending and back in 2010, put me in tears in these pimp sessions at Memorial Sloan Kettering. So I'm going to give you the hardest question, or I think probably the most important question. So you mentioned this paradigm of potentially shifting, where most of us probably would consider something like an RFA before any type of implanted device like peripheral nerve stimulation, but potentially something like this is shifting that paradigm. When you're kind of trying to figure out when to do that, when do you kind of move PNS up, do you consider, because I try to figure out this, is it about how long the pain's been around for the patient? Say a patient comes in with chronic pain for 5 years. Are they someone that you'd consider using a short-term PNS, or does that have nothing to do with it? How do you kind of approach that?
That's a very, very complex question. That comes down to, do we even know the physiology of the pain syndrome per patient? I'm not sure we have enough data to suggest duration of chronic pain of the axial back is sufficient to say that one modality will work over another. So I don't know if I could say 5 years of one will make any difference in the outcome of radiofrequency versus peripheral nerve stimulation at this time. What I do think is that you can really think this. whenever you had that lecture or question about indications and the patient population you can implant a device versus ablate, I think this is the first time where I thought, who is actually going to use a device for 2 months, take good care of it, and follow the instructions of that particular device? In New York City, I almost cannot put this device in the summer because they're going swimming. Right, the whole population goes swimming for 3 months. They're on the beach. They don't want this device in the summertime. So I don't even offer a medial branch peripheral nerve stimulator in my particular subset of patients. And some patients, maybe an ablation is the right thing to do because they can't take care of the device. On the other hand, younger patients that have axial back pain or playing sports, haven't improved after a year, still have their back pain, and maybe at risk of using opioids to maintain their back pain control, maybe this is a time we might want to consider using a device such as a peripheral nerve stimulator because they're young. You want to preserve their musculature. You may not necessarily want to destroy their core because they may run a 100-mile marathon in Leadville in Colorado someday. You think about those things, then I think you may tailor their choice one way or the other depending on the actual utility of can they use a device. So I think I see this paradigm really introducing the patient preference point and giving these options to patients, whereas many of the treatments I have always thought about, I kind of always pick the right thing. In this particular case, I think that patient preference really makes a difference in which modality we've chosen.
No, great answer there.
Just as a corollary to that, I think, if you look at the data so far, I don't think there's been a lot that suggests that duration of pain in this space is negatively predicting outcomes. So when we enrolled patients on the prospective study, we had patients who had 5 years, we had patients who had 6 months, and on and forward. So you had patients with any sort of duration of pain, and there was still consistent effect. And I don't think it was an independent negative predictor for lack of efficacy. The other thing is, and maybe, like I said, this might be a bit of a compelling statement, but I think for patients under the age of 45, I think we should be thinking about this as a first-line treatment, because why would we want to take those patients and ablate their medial branch and cause multifida atrophy and the kinds of things that Dr. Gulati presented, right? So we already know that older patients already have some multifida issues. Patients who have had long-standing low back pain have multifida issues, but why take patients that don't have multifida issues and give them multifida issues if you don't have to, right? So from my perspective, I think we really had a paradigm shift in our practice where if you're under the age of 45, sometimes even 50, we're thinking about this before we think about RF. So,
no, great answer for all of you, and I think we'll find out more as time goes by. And I think that 100-mile runner is probably pretty sane, so you should definitely do him. Shalini, Mehul, Amit, thank you all so much. It's a great session. We really appreciate it. So,
thank you very much for the invitation.
It was awesome. So let's go to the next session. I was a skeptic about SPR, as I pointed out a moment ago. I thought they were all getting infected, and I was really pleasantly surprised. I was a skeptic about the next treatment as well. When I met with the person designing the research study in 2011 or so over in Europe, I really felt it was unlikely to be successful. But then again, we saw the study and how it turned out, so it led to FDA approval. So I'll let you introduce the next session about Mainstay Medical.
Yeah, so this is, I think, again, going to pivots off nicely off the last presentation. So Mainstay Medical is going to be having Dr. Caryannopoulos and Dr. Chakravarthy talk about restorative neurostimulation for intractable chronic low back pain and talk about some of the impressive data that came out of their IDE. Gentlemen, the floor is yours.
Alexios, you're muted. You're on mute.
How's that?
Good.
Well, thank you, Tim. Thank you, Dawood. I'm excited to present some of the data from the Mainstay trial. And especially from my rehabilitative perspective as a physiatrist, this is particularly attractive to me because of the restorative nature of the therapy. So the first slide, this is a slide that many of us have used. It really shows the effect of chronic low back pain on quality of life. These patients have significantly higher scores for pain, disability, depression, anxiety, and sleep. And these effects on pain and disability can persist despite the best available medical treatments. And only a small percentage of these cases result from identified pathological condition or anatomical defect that may actually be correctable with surgery. And as such, these patients are often referred to as having non-specific low back pain. Their ability to work or to be productive is seriously affected by the condition. And this in turn results in lost days from work, disability, health resource utilization, and in turn puts a significant burden on the individuals themselves, their families, their communities, industry, and the government. Next slide. So as shown by this next slide, the prognosis of intractable low back pain is unfavorable. Patients with severe chronic low back pain obviously or often do not get better by themselves, and current available treatments don't bring long-term relief. So you can see in the data set here that 75% still have severe chronic low back pain 7 years after onset. None have had actual resolution of their chronic low back pain. And in essence, what this shows is that there are few options for these patients, and that this may be a viable option that we should really consider. Next slide. Just to put a background to what we're talking about, there's really two types of refractory chronic low back pain, and they each really require a different approach. First is the neuropathic pain or radicular pain, which in our patient population often comes about from failed back surgery syndrome. And this is a great indication for spinal cord stimulation or DRG, especially for the radicular component, although more recently now for the axial component. But in essence, what we're doing here is palliative care by stimulating the sensory fibers with leads within the spinal canal or out the foramen. And if the patient does well longitudinally, it's great, but it's not restorative per se. And spinal cord stimulation really cannot be recommended for non-specific chronic low back pain. With mechanical or nociceptive pain, which is often due to impaired muscle control, especially the multifidi muscles, there are fewer therapeutic options, and surgery is rarely indicated at all. And with restorative treatment, as opposed to spinal cord stimulation or DRG or treatments that we have for neuropathic pain, we're not just covering up or managing the pain, we're really restoring function and treating the pain. Next slide. So the majority of patients you see here in this slide, 2/3 of axial chronic low back pain is predominantly nociceptive. The majority of patients with pain really have pain from disuse or atrophy, and really less from nociceptive or neuropathic pain per se, although there can certainly be mixed patterns of neuropathic and nociceptive pain, which is important for us to understand that there are multiple pain generators in this pain population. But again, the majority of the chronic non-specific low back pain is nociceptive. Next slide. So there's impaired neuromuscular control of segmental stabilizers, which has been shown in both human and animal models. And these factors both contribute to chronic low back pain. In essence, what we're looking at is functional instability at the intersegmental level as being one of the root causes. And from a rehabilitative or an anatomical perspective, what you're looking at is the posterior stabilizing muscles, especially the deep fascicles of the lumbar multifidi, in an individual without chronic low back pain. These play an important role in maintaining intersegmental functional stability. However, if you have a single episode of debilitating low back pain, the multifidus function is often disrupted at the segmental level from what we call arthrogenic muscle inhibition, or AMI. This refers to an impairment caused by ongoing reflex inhibition of the muscles surrounding a joint or spine, and joint injury itself or some type of trauma causes arthrogenic muscle inhibition to affect the surrounding muscle as a protective mechanism to the injured area. And with chronic low back pain, dysfunction of the lumbar multifidus can thereby allow the vertebral segments to move outside their pain-free zone. And this actually increases the risk of being re-injured, leading to further motor control impairment, muscle inhibition, and chronic pain. Next slide. So what is restoration of neuromuscular control and how does it facilitate recovery? Well, this is essentially what this system looks like. And again, it's important to point out this is not spinal cord stimulation. With spinal cord stimulation, there's a palliative effect when electricity is applied to the nervous system longitudinally to cover up pain. However, Reactivate is designed to electrically stimulate the nerves responsible for contracting these muscles, which in turn improves dynamic stability, allowing the body to recover from chronic low back pain. With restorative therapy, using the system just 30 minutes twice a day will actually restore functional stability and improve neuromuscular control. Next slide. So two graphs here to see. On the right, Reactivate shows a slower initial response, but sustained and continued improvement long-term, consistent with restorative therapy. In the graph on the left, it shows that patients continue to improve over time. And at 12 months, they actually have not even plateaued. On the other side, traditional spinal cord stimulation, or HF10, shows a consistent pattern of significant short-term improvement followed by a gradual erosion of the response, which can negatively affect maintenance of therapy. And although high frequency has demonstrated superiority compared to conventional stimulation in patients with predominantly neuropathic pain, there is limited evidence of effectiveness in the other patient population, meaning nociceptive pain. High frequency was evaluated in 20 patients with predominantly back pain and no history of spinal surgery. However, the authors really can't state that this therapy should be relegated to a subset of chronic low back pain patients who present with non-specific degenerative changes at multiple vertebral levels and complain of severe back pain with characteristics of predominantly central sensitization rather than mechanical nociception. Next slide, please. All right, so this is a schematic of the actual trial design. And this came about, this Reactivate B trial design came about from an earlier Reactivate A open label trial in Europe and Australia. There were 10 clinical sites, 5 in Australia, 2 in Belgium, and 3 in the UK. And it led to the Reactivate B being a large international sham-controlled randomized trial with a one-way crossover to support FDA approval. So the primary endpoint, which you can see is the yellow triangle in the towards the right, was assessed at 120 days, and long-term outcomes were documented out to 5 years. The sham patients got unblended or crossed over to restorative therapy, whereas the therapy patients could not go to sham once the multifidus was stimulated. The primary endpoint at 120 days was the difference in responder rates between the treatment and sham control group. And a responder was defined as a patient with at least a 30% improvement in the average low back pain visual analog scale, with no increase in pain or medication for any reason in the 2 weeks prior to assessment. And this implies that the patients who take pain medication for acute pain that may be completely unrelated to low back pain count as a failure. And this was an FDA requirement. Next slide, please. Okay, so in the Reactivate B population reflects an unmet clinical need. The baseline patients of the 204 patients enrolled show that there was an average age of 47, and the majority of these patients had severe and disabling low back pain for many years. If you look on the right, the red dot, you can see where the majority of people started were with an average VAS of 7.3 and ODI of 39, which is considered severe in both arenas. Per inclusion criteria, all of them failed PT and medical management, and 37% were using opioids at baseline. More than half had previously tried interventional palliative treatments, including injections and radiofrequency ablation. And patients with indicators for low back surgery or prior surgery were excluded, as these patients had predominantly neuropathic pain. Comorbid conditions were excluded also because of confounding of pain assessment. And suffice to say, when you're looking at these statistics, these patients were severely affected by their chronic pain. Next slide. The the primary endpoint, which was the responder rate, as I alluded to before, in full disclosure, did not achieve statistical significance. And part of that was because of dichotomized data reduced both groups to above or below 30 as the response rate. And also patients who experience increased need for pain meds, which may have been related or not to their chronic back pain, were considered non-responders. So the primary efficacy of this study, again, was a comparison of responder rates. Responder rates having a 30% or greater improvement between baseline and 120 days after randomization without any increase in pain medication. And in the treatment group, the responder rate at 120 days was 56% compared to 47% in the control group, which was a difference that was not statistically significant. However, in the primary analysis, the mean VIS score did improve and did achieve statistical significance. On the right, you'll see the secondary endpoints, such as disability measured by the ODI, the quality of life measured by EQ-5D, and numerical improvements were seen in this treatment group as compared to the control group at 120 days. Not surprisingly, resolution of back pain did not see significance, which is not unexpected. After 14 years, one would not expect for it to go away over that course of time. Next slide, please. So one may ask, so why did one statistic reach significance and the other didn't? Well, it's really important to look at some statistical benchmarking and how to interpret patient-reported outcomes, or PROs. So this graph shows the entire distribution of responses for both the treatment and the control group, or what is termed as the cumulative proportion of responder analysis, or CPRA. This responder analysis uses the same intention to treat population, but does take into account the treatment response over the full range of the responses, whereas this pre-specified analysis favored the treatment over the control group with a p-value of less than 0.05. Next slide, please. So I think there's one before that. Okay, there seems to be a slide missing, but I just want to talk a little bit more about the cumulative proportion of responders. So in randomized controlled trials, there is really no single definition of a response ideal for all purposes. So this cumulative proportion, or CPRA, can be used to present the proportion of responders over an entire range of possible cutoff points over in a graph, and it has a higher statistical value and sensitivity. And this often allows the reader or the interpreter to really compare treatment groups at any responder level valid for the patient population. So whether as a primary or secondary approach to a clinical trial of pain therapy, the display of this data may be useful in understanding of the results and applicability to patient care in general. So if you look at our data, the totality of the data is what the FDA used to approve the treatment. So in essence, the therapeutic stimulation was found to be efficacious and did have statistical significance greater than sham. And because there was a very high responder rate in the patients in the treatment group, these treatments were sustained at 1 year, and there were substantial improvements in the patients that were crossed over to treatment from the control group after 120 days. And these long-term results represent the most important clinical factors to all of us who are listening to this call and to patients themselves. Next slide, please. All right, sorry, can you go back one? I think this seems to be all right. So it's important to really look at this data from the perspective of functional restoration, not just pain. And it's also important to understand what is a good clinical trial. So why is it at 3 months there was little difference in the two groups, whereas other trials show significant placebo effect at the first 3 months? So this is really not a surprise. However, we really didn't expect the sham response to be so big. So although we did not study the control group after 120 days, all sham subjects did cross over, and once crossed over, these patients had a significantly greater improvement of sham over time. So on this, actually just go back one, please. Okay, so with respect to this slide, on the left, you note that the proportion of patients with greater than 50% improvement in VAS increases over time. Until 120 days, the control does not improve until crossed over. On the right, you note that there are substantial improvements in ODI over time. In the treatment group, 77% of patients have a greater than or equal to 10-point improvement, and 55% of patients have a greater than or equal to 20-point improvement, which is deemed substantial. In the control crossover group, 80% of patients had a greater than or equal to 10-point improvement, whereas 60% of patients have greater than or equal to 20-point improvement. And typically, ODI improvement in patients greater than 10 is considered to be clinically significant in terms of response. But with the work of Robert Chu and Rick Deo, they defined a greater than 20-point improvement as a substantial response for patients treated with low back pain. And in part, this gets to the fact that secondary outcome measures were statistically significant in this patient population. Next slide, please. All right, so these are tornado plots for anybody who doesn't recognize them, which are highlighted in the HF10 trials. And overall, what you're looking at is the proportion of patients in the full data set with a minimally clinically significant change in VAS or ODI. Next slide, please. All right, so this slide shows substantial individual improvements in VAS and ODI at 1 year. So on the Y or vertical axis, if you look at the -2 or highlighted area, those are the patients that had substantial change or improvement in the ODI, whereas on the X or horizontal axis, only patients to the left of that -2 had substantial change or improvement in VAS scores. In total, there was 75% had improvement in VAS and 56% had improvement in ODI. Now, if you share that data or commingle that data, let's go to the next slide. So patients that had improvement in VAS or ODI were 79%. Next slide. Whereas patients who had improvements in VAS and ODI were 55%. So those are both significant numbers. All right, next slide, please. Next, please. Okay, one more. I think we're going, keep going, please. Okay, I think there was a mismatch in the slides that I gave, and I apologize. So when you look at the safety profile compared to published data, the incidence and type of adverse events really compares favorably to that of published data on spinal cord stimulator devices. These adverse events, including any serious adverse events, were comparable to AEs in clinical trials reported for other neurostimulation devices. In our trial, there were no unanticipated adverse events related to the device, the procedure itself, or the stimulation. If you look on the upper right, there was a statistic of 40% that had implant site pain, but this also included the 2-week follow-up, whereby it would be reasonable to have pain over the incision area. And the total number of those patients, 14%, represented 28 patients, and 17 of the 28 patients resolved, whereas 13 out of 17 resolved without surgery, and 4 out of 17 resolved with repositioning the IPG itself. It's also important to note midway down on the right that there were no instances of lead migration. So this safety profile, combined with the efficacy data in this study and the lack of available treatment alternatives for this particular patient population, suggests that Reactivate can be a promising therapy for patients with chronic low back pain when compared to the responder rates and safety profiles of alternative treatments, and also when compared to other implantable neurostimulation devices, which includes no migration of leads. Next slide, please. All right, so while the trial missed its 120-day primary endpoint, We really believe that the long-term results are compelling and important. That's particularly important because these patients have not experienced meaningful pain relief from other existing treatments. The data shows that 60% of patients experience a 50% or greater pain reduction at 1 year, and this surpasses what many implanting physicians expected from any implantable neurostimulation device. The literature from other sham or placebo-controlled studies involving drugs, implants, or other interventions suggests that a responder rate of 20% or more could have been expected in this control group. However, our study assumed a 25% responder rate in the control. So this really speaks to the quality of the study design itself. Next slide. All right, in conclusion, so Reactivate-B is the first ever active sham-controlled clinical trial of an implantable neurostimulator for chronic non-specific low back pain. Restorative neurostimulation is a safe, effective, and durable treatment. All outcomes continue to improve with longer therapy duration. The trajectory and durability are consistent with the restorative mechanism. And restorative neurostimulation is complementary to STEM. It doesn't necessarily compete with the other, because we know that there are difference in targets for neuropathic versus nociceptive pain. At key time points, 6 months to 1 year after Reactivate is activated, key measures of pain, disability, quality of life, and medication usage showed sizable improvements. In fact, at 120 days, patients were allowed to adjust their back pain medication. And at 1 year, the majority of these patients who were on opioids at baseline had voluntarily eliminated or significantly reduced their use of opioids. Another positive characteristic, in contrast to other analgesic therapies, is that the response rate in individual patient condition continues to improve over time. And this is what you'd expect from a rehabilitative therapy, and certainly not from a placebo response. Finally, while the performance compares favorably to commercial available neurostimulation for pain, there were very few side effects and no lead migration.
So Alexios, great job. I think you did a phenomenal job presenting the data. We just have time for 2 quick questions. I'm going to ask you the first one. So what about that? So we were involved in the study, so I think it was a great study, and I think I'm impressed by yourself and Chris Gilligan and others who got this through the FDA approval process, because as you pointed out, the initial endpoint wasn't met, but 1 year looked quite good. Could this be a tool we put in someone and it's in for a few years and then they're cured? And we don't need to have it in any longer. We were able to explant them. Can you ever see that as a possibility? Because it looks like you're getting better all the time with this device.
Tim, thank you. It's a great question. I think as we get more data from this data set, and as we continue to look at the trajectory, certainly it would suggest that these patients would have a cure or a fix. Now, whether that would be sustained over time and whether these patients might need sort of maintenance therapy or turning it on every now and then to remind them, just like patients who go to physical therapy and they get improvements, but if they forget to do their home therapy or their homework per se, they could regress. So I think I'd like to think that this would really cure their back pain, but I really think the data will pan out as to where we go. And I think it also speaks to this patient population. These patients are chronic pain people, and they have tried most things, and one of the things that's often failing is this rehabilitation approach or ability to engage in PT for weakness of the core stabilizers, and this may be the thing that allows them to move forward.
That's a great answer. So I think, we were also involved in the study, and we were kind of surprised they didn't meet the primary endpoint, because we saw a lot of these patients and they all did quite well. And it looks like maybe perhaps this study was just designed incorrectly. But just a practical question, since this is now FDA approved and it's going to be in our hands. With traditional spinal cord stimulation, we all kind of feel like we can select patients appropriately by doing a trial. In this study, we did not do trials. So as this becomes more widely available, what's your advice for people to select patients for this? What tools do you use?
Well, I think one of the most important things is just looking at the history and doing a physical examination and really teasing out what the other potential pain generators could be. In our trial, we had the advantage of having a surgeon and a radiologist help to qualify which patients would be surgical candidates or not. And all of these patients involved had either had failed all conventional treatment. So I think it's really imperative, and you bring up a great point, that each patient needs to be assessed individually. And I think it's really important to look at their treatment history, talk to the patient, really get an understanding of where the pain generation can be. There are some rehabilitative techniques, or one in particular, which can help to assess whether the multifidi is atrophied or not working appropriately. But I think, you know, I don't think you can necessarily compare this to doing a medial branch block for an RFA, because you know, that's really a palliative pain treatment, where this is really restorative.
Oh, great answer, Alexios. It's wonderful to see you, Alexios. Great job.
Thank you, Tim.
And hope to see you in Boston sometime soon, my friend. Take care.
Likewise.
Thanks,
All
Alexios.
right.
Great job.
Our next session will be introduced by Dawood, and we're going to go back, Dawood, to another new device that FDA has approved in the last few years. So I'll give to you to introduce a great potential therapy for our patients.
Yeah, absolutely. So we were able to have a panel from Nalu on our spinal cord stimulation session just a few days ago, but also Nalu has also come to the market with a PNS system. So again, they're going to talk about how this small size without compromise and how we can expand our patient population in peripheral nerve stimulation, and three really fantastic speakers, Dr. Spinner, Dr. Hah, and Dr. Ottestad.
All right. Thanks so much, Dawood, for the introduction. We're going to dive right in. I'm super excited to talk really about the distinctiveness of this Nalu neurostimulation technology. And herein lies the point. Here we have our first true micro IPG. So on the left-hand side, you can see kind of the traditional size and the shape and the thickness of a IPG you'd think about even for spinal cord stimulation. But here on the right-hand side, you can see that the Nalu IPG is really smaller than your own thumbnail, smaller than the surface of a dime, and up to 27 times smaller in overall volume than the traditional IPG. And so the advantage here being that our implant is going to be less invasive. Patients are going to be able to recover a lot sooner, and so they'll be able to get on their way with using the therapy themselves. Let's go to the next slide, please. And here we see that there are many different system configurations. When we're talking about PNS, we have this 4-contact tined lead, definitely a great option when we're thinking about permanent implantation and to prevent lead migration. But we also have here an 8-contact lead that is available both for SCS as well as PNS. And then you can see the connection configurations. We can use that single contact 4-contact lead, the single 8-contact lead, even up to a dual 8-contact lead system to simultaneously hook up leads from both sides of the body to our micro IPG. And on the right side, you see here the patient peripherals. So the Nalu device really does put the technology in the hands of the patients. They're able to interact with their device with the smartphone. You also see here a therapy disc. So the therapy disc really separates the IPG capabilities in terms of the precision of delivering the type of peripheral nerve stimulation from the electricity itself. And the nice thing I think is that this therapy disc does not have to be implanted to a patient. And I know that many times when I'm trying to have that discussion about SCS, for example, there is some hesitancy. You know, this battery is going to be in my body, and I think this is a big advantage that we're able to separate it out and that patients aren't going to have to go back to the operating room just to replace a battery, for example. So they typically will get 2 of these. So one is ready, fully charged and ready to go, while the other one is being used. Let's go to the next slide. Here, I'm not going to go through all of the details, but I think we've had a wonderful discussion up to this point in terms of what peripheral nerve stimulation has to offer, whether we're targeting the sensory aspects of pain, whether we're targeting more of the rehabilitation approach to pain. But what I want to really highlight is that this Nalu system is bringing what we traditionally think of as SCS capabilities to our PNS potential PNS patients. So we have the ability for current steering, tonic, high or low frequency administration, up to 1500 hertz. And here in the blue, we see all of the other advanced programming setups that are available. So one of the things I'm particularly excited about that I'll give you an example is when patients need both the sensory and the motor stimulation. So this device really allows for layering of programming. So maybe part of the time we'll be able to focus on the rehabilitation. Another portion of the time we can target the sensory aspect. And so one of the things I love to tell patients is that this device is going to not only grow with the science as we learn more about peripheral nerve stimulation, this should also grow with the patient and their needs. So over time, if we're talking more about rehabilitation, they'll be able to go in that direction. And if it really remains a pain issue, that they'll be able to maintain that sensory stimulation over time. Let's go to the next slide. So I'm going to hand it over to Dr. Spinner to talk about the patient equation.
Okay, thanks for the introduction. The patient equation. So there's really a sea change in peripheral nerve stimulation, and we're seeing this, and this has been talked about in a prior talk tonight, and again we're going to harp on this because this is really a change in the way we're thinking about practicing pain medicine, and that's important. So the old equation, we take a singular nerve injury, a mononeuropathic pain, and we look at some standard approaches, whether it's the neuropathic medicines, nerve blocks, RF, whether heating or burning or pulsing, right? But then as we get beyond that, past sort of the things that we do, we're looking at nerve surgeries, and then last resort was always spinal cord stim and intrathecal therapies. And so we're learning that the sooner you get to nerves, the better, right? So now our new equation is really with a monopathic nerve injury. If you understand the nerve affected, we're no longer waiting years of therapy, medications, more surgeries, other devices. We're going straight to a PNS algorithm. And like Jen just mentioned, what's interesting here is that we have specific, to take the ability of the SCS mindset that a lot of pain physicians have had for a long time, and sort of, I think, wanting to apply to the periphery, but wasn't able to before because of certain design of devices. Now we're able to use that waveform in the peripheral nerve stim world. So next slide. Right, so the way it's set up, so we start with a wear study, and it's important. So I'm holding one of the therapy discs. You get a sense based on the size of my hand, my face, and how big it is. It's pretty small, smaller than the palm of my hand. Has a pretty low profile as well. So the patients wear the therapy disc for a couple of days to a week. Want to get a sense of location of where you'll place this near your IPG as well. Make sure that the patient can actually wear it in a comfortable position. It helps also, I think, plan your procedure, your surgical procedure, and also I think gets a little buy-in from the patient as well. If you don't have an active participant on the other side of the aisle, we're not going to have a good outcome, right? So the trial is important here. So this is interesting. This is where I think where a lot of people talk about peripheral nerve pathology and if you need to trial, right? And so here we have a specific trial you're able to do with the 8 contact lead, right? And also you could throw leads in different directions, which is a really nice algorithm to be able to use. So you have a dedicated trial specific for this, which you don't always have in other cases. And then the step 3 is a permanent implant. The incisions are very small. It really is mostly a percutaneous procedure, but there is one small incision to implant the IPG and sort of bury and coil some of the wires. And then long-term follow-up, obviously, right? We want to be able to maintain. And one of the issues and one of the things that's really nice with this is the long-term ability to hopefully get pain relief, to not have to repeat procedure. And I think that's where a lot of the peripheral nerve historically has been with nerve blocks and pulse RFs and cryos. And so now we're at a place where we could treat early and treat long-term. Next slide. Right, so here wear study, right? So the first step, ensure patient's comfort with there's a clip, and I have the clip right here. One of my patients brought it in today. So it comes in an adhesive package. The therapy clip, it's the same size as when you have an ostomy, so it's the same prior adhesive technology that's been done by thousands of patients across the country, something we're all very comfortable with. Okay, so it's the same adhesive clip and disc. So patients wear for about a week, get a sense of location, and if it's a viable option for them as well. Okay, and what's nice also is that the representative from the company is always really helpful to make sure placement, the wearable, and even give a relief belt if needed to help with like a thigh or an arm placement to make sure everything holds nicely. Okay, the next slide. All right, so temporary trials, so similar to spinal cord stimulation, and this is something I think we're all comfortable with. So you percutaneously place the leads next to your nerve. Okay, and what's nice is you can really customize your therapy. So there's really a lot of programming options with this. We have the whole SCS world into the periphery as far as is concerned. So areas of focus. So we don't just look at 0 to 10, pain numeric scores. We want to look at functional ability, sleep, mood, see if there's any decrease in medication use, and all those are important. I think everyone's really looking at this because this is really the future of what we're doing. So you can measure that over the course of that week to see if a patient had good relief. Next slide. Right, so here's a closer just picture of the trial. So 8 contacts, no tines. Obviously the time leads we're not going to use for a trial. They hold really well, right? And so that's going to be for your permanent implant. So you have plenty of lead to 60 centimeters on the lead. You can, in theory, leave it in for longer than a week, but typically our standard trial is a week. So you have the trial therapy disc, an external interface cable, very similar to our SCS devices that we're used to. The cable electrodes simply slide in and you snap it in. And you wear it. I typically use a stay fixed dressing to adhere the wire where it exits the skin, and it makes just for a nice sort of closure of that. So stay fixed dressing works really well with the trial here. So next slide. Right, so the permanent procedure, I typically follow about 2 to 3 weeks after the trial. So once you demonstrate some pain relief, we don't wait, too long to go ahead and place. It really is a minimally invasive surgery. Like I said, it's mostly percutaneous except for one incision to implant the IPG. The IPG is very small and it has 2 little tongues on it. So I often place actually 2 leads when I'm doing something like this. So in the picture here, you see sort of an example of a ilioinguinal or hypogastric nerve. I see a lot of male pelvic pain. I'll often throw in a lead here and also general femoral branch, and I do similar for knees and shoulders, and that'll be discussed in a little bit. But I like to throw in 2 leads to get complete coverage. And with this, you really have a nice option of doing that as well. Okay, and then the programming is done, once everything heals. The next slide. Right, so long-term follow-up, obviously, all patients are being tracked. We want to look for good pain relief, and not just pain from a numeric scale. We want to make sure they're walking, they're happy, they're sleeping, they're not taking as much opiates. We really want to get to these patients early. And we know from all the research being done across the spectrum that the sooner we get to these nerves, the better. And so Nalu has a really innovative software package, I think, that's stimulating the nerves very well in this field. So next slide. Back to Jen.
All right, thank you so much, Dr. Spinner. So we're going to talk a little bit about PNS indications. Where can we place this Nalu neurostimulation technology in the peripheral nerve space? So let's start with the arm. This seems like a really good target. We've got a lot of distal forearm nerves, radial, ulnar, median. I would say that some of the points to consider when you're thinking about a trial or permanent implantation is that you got the elbow and the wrist in the way, as well as just how superficial are your targets, and making sure that we implant deeply enough to prevent any type of complications. When we're talking about the shoulder, there's so many shoulder pain indications that could work with peripheral nerve stimulation. We've got the general shoulder osteoarthritis, post-trauma pain, post-surgical pain, even post-stroke pain. And so our 2 main targets for shoulder would be the suprascapular nerve. So we typically think of this when we're thinking of the refractory glenohumeral joint pain, as well as pain related to the super and infraspinatus muscles. And then a separate target would be your axillary nerve. So that's more going to be for a lateral shoulder pain. So when we're thinking about which type of target to start with, I think if you're just starting to get familiar with this technology, I would recommend sticking with a more superficial target. So I would say that the suprascapular target would be a little bit more of an advanced approach. Next slide. And here we have a plethora of lower extremity targets, and then my favorite would be pelvis and trunk targets. But let's talk a little bit about what are our lower extremity targets and the ideal patient. So definitely if you have an amputation patient who has a phantom limb pain or just residual stump pain, they would be great candidates for stimulation of femoral or sciatic nerve targets or a combined approach. And again, we have that option because we can place 2 of those 8 contact leads simultaneously per IPG. You've got your saphenous nerve as a great target even for patients who are post-total knee arthroplasty. Now, when we're talking about a nerve that's a little bit more of a softball in terms of getting familiar with the device and implantation and the trial process, I would personally recommend the lateral femoral cutaneous nerve as a great target because it does not have that motor function. It's purely sensory, and despite or regardless of the patient's body habitus, tends to be fairly shallow. So I like this as a fairly forgiving target. We know we have a huge and broad differential for meralgia paresthetica, so I think that would be a great one to get familiar with. And then as we move further down the lower extremity, we've got the common peroneal and tibial nerve and all of the associated branches there. In terms of the trunk and pelvis, of course, there are way more options than just what's listed, but commonly the intercostal nerves are a great target if you've got somebody who has a post-herpetic neuralgia, for example, or some sort of post-traumatic rib fracture pain. The ilioinguinal, iliohypogastric nerves, as Dr. Spinner had showed in his diagram, an excellent target, especially if you have a patient who's post-surgical. We know that there's a lot of retraction on these nerves when you make a fan and steel incision, so commonly see this type of neuralgia in a patient who's post-hysterectomy, and also for those who have hernia repair. So we know post-hernia raphe pain very often is related to these ilioinguinal and iliohypogastric nerves. Now, one of the age-old conundrums we have at this point is, do we do a full contact parallel lead placement approach, or do we just contact one point along the nerve? So I think that in terms of all of those listed, that I wouldn't necessarily start with the ilioinguinal and iliohypogastric as your first targets. Another debate that's ongoing is whether or not you need ultrasound guidance for the PNS placement versus fluoroscopy. And I think generally what I would recommend, and maybe what my colleagues would recommend as well, is whatever is your most familiar technique, and ideally you have done some preliminary work in the diagnostic approach. Perhaps you have tried some diagnostic blocks, and so you know that you can find that target, maybe find some pain relief. And so in that sense, yes, you could use ultrasound. For example, we see here the target clearly for the suprascapular nerve in the suprascapular notch. This is with ultrasound guidance. However, if fluoroscopy has been your mainstay and your go-to, that is totally appropriate as well. Next slide. So just to review in terms of ultrasound targets, what would be the advantages of kind of transitioning from fluoroscopy to ultrasound guidance over time? Aside from just the immediate benefits of being able to scan for additional structures such as arteries and veins using color Doppler, I would say that we're really trying to stress the importance of precision in our placement. So for us at Stanford, for example, we commonly will obtain MR neurography imaging. That gives us a sense of where exactly is this neuroma, making sure that we're placing our leads in proximity to where we think there is a lesion along the nerve. And so using the ultrasound actually will help us, for example, to scan for the enhanced diameter, the indicative of some sort of neuroma. So really we can ideally place a therapy at the best point so that we're not distal to where the problem or the pathology exists. Let's go to the next slide. So here are some common fluoroscopy targets. Again, it's completely fine. I can continue to brainstorm additional fluoroscopy targets. For example, the pudendal nerve is typically fairly deep and the ischial spine is easy to visualize. So if that is your approach to that nerve, for example, then I would say go with what is most comfortable for you. Next slide. And this is just, again, showing us, what are the advantages of using the ultrasound guided approach versus using fluoroscopy. I think one of the main advantages is really placing our leads parallel to the course of the nerve, getting maximal contact of our 4 or 8 contact leads right along the path of the nerve, identifying our proper target. Another thing to emphasize is the speed of the procedure. Now, I've noticed this phenomenon where if it's taking more than one pass at trying to find the optimal target for your PNS, that over time the nerve can get swollen and difficult to stimulate. So I would say that there is a big advantage to the speed of the procedure, whichever one is faster in terms of finding the ideal stimulation and placing the device. And that will also aid for patient comfort. Next slide. So I'm going to hand it over. This is really exciting. Dr. Ottestad is going to go over an actual case implantation so we can see how the device works in reality.
All right, thank you, Jen, for that wonderful talk on the device so far and all the indications. So I actually have one of my long-term patients here I first met maybe 5 years ago in a little bit of a whirlwind encounter. I'm sure you've all had similar types of patients, but she presented in a little bit of a dramatic way with a story where her doctors ruined her 14 years ago. So it was a pretty hardcore introduction to that patient encounter, I think. But essentially, she took a statin and had what sounds like a myopathy leading to some weakness. In her mind, she was paralyzed by the doctors by this drug and was wheelchair bound for years. As mentioned, I think it was mostly just a myopathy and some weakness, but it sounded like she did end up with some neuropathic pain as a result of this process. And she went through, when she developed the pain, she essentially had total body pain at the site of essentially maybe a T4, T5, T6 lesion with burning pain going all the way down to the feet. And then over the course of maybe 3, 4, 5 years, she describes how she recovered from the injury and the pain slowly resolved in a descending pattern all the way down her buttocks, her legs, her knees, down to her foot. But what remained was essentially a tibial neuropathy. So the pain resolved for the rest of her leg, but never resolved in her great toe and that bottom of the foot portion. Now, she had a lot of very appropriate treatment, the various types of medications that you would expect, as well as a spinal cord stimulator trial. Now, she actually had a very successful spinal cord stimulator trial that resolved her foot pain, but she unfortunately had another complication with the implant procedure. So she had a paddle lead placed, and at the time of placement, it sounds like the cord was dinged a little bit, and it was immediately explanted after that. Now, she was naturally a bit of a skeptic to further spinal cord stimulation types of procedures at this point. So when I met her, I had essentially a story of neuropathic pain that responded well to a spinal cord trial, but she wasn't able to have any sort of permanent implant. So I essentially started off with a temporary peripheral nerve stimulator. So this was placed on the sciatic nerve in the back of the calf. And it worked really well. And the way I knew it worked really well is by the volume of her emails. So essentially, after meeting her, I would probably get 5 emails a week with a lot of anxiety and a lot of rumination about the past. Once the stimulator went in, I saw a decrease in the volume of those emails. So not only was she reporting that her pain was getting better, she showed me functional improvement as well, in that she didn't bother me quite as much. Now, at the end of the 2-month period, the leads came out and the pain returned, and we talked about various options, and we decided to do a repeat treatment. And once again, she did great for 2 months. At the end of this, we still had that same situation where I now had a patient who responded really great to both central as well as peripheral stimulation. I just needed a more permanent version, so I did that next. And once again, she responded great to the permanent peripheral nerve stimulator symptoms. She unfortunately developed, can we go back one slide, please? She developed a little bit of an allergy to the patch. You can see in the back of the calves a little bit of a red spot where the allergy is. And essentially, in the bottom left on this slide, we see an ultrasound image. There's a black circle kind of in the middle. That's the tibial artery. The nerve is not very clear, but it's essentially adjacent to it. And you can see I have the patient positioned prone here so that I can access both tibial nerves at the same time. And what you're seeing is the markings for the disc up top. And my ultrasound probe is on the medial leg by the medial malleolus, finding the nerve. Now we can do the next slide. So in terms of the approach, I find the nerve out of plane as well as in plane. And the picture on the left here, we can see the introducer placement. This is going to be the step 1, is to try to get this introducer essentially parallel and adjacent to the nerve using whichever approach you're the most comfortable with. And then the next step is to advance the lead inside your introducer. just take the silate out, put the lead in, and there's a nice white marking on that that tells you when the electrodes are sticking out your introducer. And at that point, you can actually go ahead and do your paresthesia testing on the lead in the patient to make sure you're capturing the right area, as Dr. Spinner alluded to. The next step is then to create a pocket, and we've already marked out where that pocket is going to go. And I'm using the Nalu pocket tunneling tools to create the pocket that will fit the IPG. And then our fourth picture, this is after the tunneling, and I've left a little bit of a retention loop in the original incision, as you can see. And my IPG has been connected in the battery pocket. And then the final step is simply to slide that IPG right under my purple marking over that site. And the next slide. And here on the left side, we can see an in plane view of our introducer on top of the tibial nerve. And the tibial nerve is going to the left to the right side of the screen. And I can essentially watch the lead come out adjacent to the nerve and then do the paresthesia testing. In this case, she did really well with the system. She did great with the previous systems as well, but she had a fairly immediate decrease in her pain scores by 70%. So from a 10 down to a 3, as well as an increase in functional ability. And in her case, walking her 2 pugs is usually the thing of contention. So she's able to do that without any problems using this particular device. Now, one thing that's interesting with her is the volume of emails, as mentioned. And I went from the initial volume of probably 10 emails a week that used to generally go down with implants. And then once we got this Nalu implant in, now I think a month and a half ago, I actually haven't had any further emails from her. So I think she's still doing fantastic with the device. I have her verbal kind of confirmation that it works, but also the functional improvements, as well as, once again, when she doesn't contact me on a daily basis, I know she's actually doing really, really well. Next slide. No, that's it. So thank you. I'll turn it back.
No, great job by all 3 of you. I think I learned a lot from that. I've seen these procedures many times and learned a lot. We're out of time, but I'd just like to give you each maybe 20 seconds to give us what you think is a really important pearl about this therapy. Jennifer, we'll start with you.
Oh, great. The ability to do the trial before the implantation. This is a huge game changer, can be trialed for up to 30 days.
No, I love that. David?
So for me, it's programming. I think there's a lot of monopolar, and so now we get to use the whole world of spine and put in the periphery, I think, in the way we would like to do.
A great point. Einar?
Yeah, I also like the benefit of being able to power 2 leads with a single generator. So I think 3 good benefits here.
That was an amazing job. Thank you all so much. I'm really, really impressed and greatly appreciate all of you.
Yeah, great job by everyone, and thank you for participating.
Thanks for having us.
Thanks.
Great. See you soon, hopefully.
So now we're going to pivot a bit and go to RF ablation. Our great friend, Dr. Stanley Golovac in Miami, Florida, always looking dapper as always, is going to talk about Epimed, innovation in radiofrequency ablation, improving the safety and efficacy of RF ablation. Stanley, please take it.
Take it away, Stan.
Hey, Dawood. Hey, Tim, how are you? Hope everyone in webinar world is doing great. So, you know, radiofrequency ablation is one of these therapies that we all should command in our wheelhouse. It's a therapy that just suits what we do in pain management. You know, physicians, much like Ricardo Vallejo and myself, really have honored the value of what radiofrequency ablation does for a patient. Next slide, please. And so in order to incorporate and really value what we do, Epimed and I have partnered up to introduce a concept of a style of ablation that offers yet safety and targeting to be able to really target the nerve that one really wants to ablate and have a little bit of a fudge factor built in there. So the creation of this needle is called accuracy, being a little much of a play on words, to accurately place the needle next to a nerve that needs to be ablated. All of us, you know, appreciate the value of anatomy, but it's not always consistent. Sometimes there's a little bit of a nuance that creates the aberration, if you will, of the nerve not being exactly where it needs to be. So when you place a nerve and a needle next to each other, you know, the size of the radiofrequency ablation tends to be between 4, 5, and 6 millimeters. And the nerve that you're trying to ablate is actually 2 millimeters in diameter. So if you're off by just a couple of millimeters, you tend to either miss the nerve or not entirely ablate the nerve. So the value of utilizing a needle, such as the accuracy, allows for a 9 millimeter ablation that allows you to have a little bit more of a fudge factor just in case you're off the center of where your target needs to be. Next slide, please. So the design of this needle came about from thinking about, you know, the standard needle that was made way back in 1670, a hollow hypodermic needle with the injectate going forward. But if you really think about it, when we ablate nerves and we ablate median branches in the cervical, the thoracic, the lumbar, and pretty much anywhere else in the periphery of where we target, we really don't even anesthetize the targeted nerve. We may anesthetize the root or we anesthetize the takeoff, but we don't really anesthetize the nerve itself because the solution of our anesthetic or whatever fluid you choose goes forward. So what I thought was, you know, if I put a bead at the end of the needle and occlude the tip and then create a sieve around the actual tip of the needle, you could create a spritz, and that spritz would then encircle and encompass the targeted area. Next slide, please. And so the design of this needle really came about from thinking about what, you know, we need to do to accurately place this needle next to the nerve. So once in place, using fluoroscopy, of course, or ultrasound guidance, the needle actually stays in place because the actual connector here allows you to administer local anesthetic through the connector without having to remove the probe or have to move the needle. So this allows for a more precise placement, a more accurate placement without having to reattach the probe or reattach the local anesthetic. So once in place, you're done. Next slide, please. So the lumbar area, as we all know, is a pretty consistent area from L1 all the way down to L5. But to ablate this area, you really need to be not in the intertransverse ligament or the mammal accessory ligament. So you want to ablate 3/5 of the nerve. Aaron Kolodny taught me this years ago. You know, you have to be parallel and next to the nerve. So if you place your needle next to the nerve, you'll have the most exposure of the needle ablating the nerve, therefore allowing for the entire area to be ablated and the patient to be improved. Next slide, Michelle. So once it's in place, your needle should be placed parallel to that target. And Eric Lee and I have gone over this many times. You know, punctate placement or perpendicular placement is not enough to suffice actually placing the needle next to the nerve to actually improve the dynamics of ablating the entire segment. So parallel placement is pretty much imperative. And we saw this earlier with Dr. Desai as he was showing how the peripheral stim placement was utilized, coming from the inferior aspect of the joint to the superior aspect of the joint, allows you to place this parallel to the nerve, ablating the majority of the nerve versus only a segment. Next slide, please. So again, a protocol was developed in order to be able to prove and definitely redefine what ablation can do from a lumbar approach utilizing this nerve. So fluid is injected near the target, utilizing a side port, allowing for that injectate to reach the targeted area. Even if the nerve is farther away than anticipated, remember, you're almost going to get a 9 millimeter burn. That is a huge improvement from a standardized needle that I'll show you in just a few minutes. Next slide, please. So the cervical area, you know, is one of my real challenge places to ablate. It's one of the most consistent, inconsistent nerves to find. So typically, as I learned from Nikolai Bogdach and from Professor Rick Derby, placing a needle in the centroid portion of the bone on the cervical spine is usually not sufficient enough. You usually have to burn up the wall, down the wall, and in the center of the centroid portion. But utilizing an accuracy needle may allow you to avoid having to move the needle or ablate multiple segments. This way, you have a 9 millimeter burn encompassing the most superior aspect of the joint and the most inferior aspect of the joint. Therefore, the centroid portion, the needle placed in the center of the centroid, should allow you to ablate the entire area. Next slide, please. The thoracic spine is another big challenge. I was asked to review a case 2 days ago, and again, your mind just goes to the individual who believes and appreciates that the nerve follows the same pathway as it does in the lumbar area. Well, it doesn't. Unfortunately, from T1 down to T5, the nerve is never found on top of the SAP. It's always inside the intertransverse. So your needle needs to be right between one transverse process and another. And as it gets down from T6 all the way down to T12, it begins to approximate itself towards the joint. But again, if you don't place the needle in the proper placement and allow for a large enough burn, you tend to miss the target. Next slide, please. So this shows a standard 20 gauge needle. You can see the elliptical shape of the actual burn. And this is a typical standard straightforward burn that occurs with conventional needles. The accuracy allows for a huge improvement, about 2.5 times the size of cubic millimeters than a standard radiofrequency ablation. Again, allowing for that fudge factor just in case you don't place the needle exactly on the target. This is extremely important because most of us understand and appreciate that anatomy is always not as consistent as we think it is. So therefore, having something that allows us to burn a little larger than normal may be an improvement in our overall therapy. Now, Tim Deere and I have had this discussion in the past. There are no randomized controlled studies proving that a larger lesion is actually better. And I agree 100% with him. But I also have a fact that he and I have also agreed on, and that is a smaller lesion will guarantee that you don't get the target. So a larger lesion is actually an added benefit, an added feature that is a necessity in order to encompass the variability in our patient's anatomy. Next slide, please. So here I've shown a little bit of a diagram. And if you look at the inferior margin on this burn area, this is a conventional 20 gauge standard radiofrequency needle. Nothing added, nothing additional. So we did some testing at Epimed and look at the lesion size by doing incremental improvement in solution addition to the RF ablation. If you place 0.25 mLs of your solution at the beginning, and then at 25 seconds, and then at 60 seconds, look what happens to the lesion size. It seems to be mounting one on top of the other. Again, the lesion size demonstrates that larger does encompass the variability in our nerve's placement anatomically. Next slide, please. So the accuracy availability is manufactured and sold through Epimed, something that is really improved in our ability to have access to a 20 gauge 1010 active tip with a side port, only compatible with Epimed nitinol and stainless steel probes. For more information, please contact accuracy@epimed.com. Next slide, please. Boutique needles have come into vogue, and we've heard from a lot of our friends on different webinars when we talk about the Venom, when we talk about Nimbus, and we talk about accuracy and others. But in the future, we're going to begin to think about unidirectional RF stimulation and RF ablation. So this is the Rolu, and the Rolu allows us to have a unidirectional ability to actually ablate. So think of this if you were placing this next to a blood vessel. Think of this if you were in the splanchnic area, T10, T11, adjacent to the pulmonic structures, adjacent to vascular structures. Would you want your lesion to be 360 degrees, or would you want it to be unidirectional? Think of you are doing a celiac plexus block. Here's your needle placed right adjacent to the aorta or the inferior vena cava, and lo and behold, you would want your direction of your lesioning to be on one side versus the other. So this is a needle and a targeted way of demonstrating that your RF ablation can be unidirectional. Again, thinking about the future, something about what may be changing and game changing as we move forward, thinking about how to target and ablate structures a little bit larger, a little bit more unidirectional, a little bit more target specific. So I want to thank everybody for joining us and attending. Thank you, Tim, and thanks, Dawood, for this ability to share this information.
Stan, you never cease to impress me, my friend. Great job with both accuracy and Rulu. We have time for one question from both of us. I think my question is, you know, we talked about studies. What study, if you were designing a study in the spine to show a larger lesion mattered, what would you look at? How would you design that study? Just very briefly.
Wow, that's a great question. You know, we've never had a head-to-head randomized controlled study to even do that. So we'd have to show and demonstrate that in structures that are very sensitive to having vascular structures or pulmonic structures, that we can definitely target and specifically ablate the area that's intended versus any adjacent sensitive structures. And so I would create a study that, you know, would be sort of a splanchnic or a cervical headache, where the structures are very delicate and very target specific, and utilizing a needle that is very target ablation wise to be right on point.
Nice. Dawood?
Yeah, Stan, I think this is all really fascinating. I think we look in other parts of our field that have really advanced, and RF has been fairly stagnant over the last few years. And this is really exciting as we kind of get to advance this part of our field, which makes up a large part of most of our practice when we talk about RF ablation. So when I was taught just 10 short years ago, you know, sensory and motor stimulation prior to an ablation was like considered standard of care. Now, when we talk about, you know, these new boutique needles forming these really large lesions, is sensory and motor testing prior to an ablation going to be more important, less important, or really no change, or should we stop doing it?
Another great question. Thanks, Dawood. You know, it all has to do with the level of sensitivity and sedation that the patient somewhat requires. You know, because if you begin to sedate a patient, they really don't have that sensory capacity to tell you that you're really right on target. The motor value is that you're not, you know, adjacent to the motor complex of the nerve structure that could be injuring the patient instead of ablating them. But I think as we design needles to be very target specific, I think we're going to probably use less testing and sensitivity, because the patients want to be comfortable. And if we're going to make our patients comfortable, we're going to have to really rely on the technology and the availability of understanding the science of where the needle placement is, and are you target specific, so therefore you can hit a home run with the ablation.
A great answer, Stan. Thank you so much. We appreciate you joining us tonight.
Thank you very much, gentlemen. Have a great evening. Thank you.
Talk to you soon.
You bet.
We'll go to the next session now. Dawood, you want to introduce the session?
Yeah, so absolutely. So as we continue on this RF theme, we're going to have Abbott and some of their key opinion leaders include us on a roundtable discussion on the theory and application of radiofrequency ablation and pain management. This session will include Dr. Jason Pope, Dr. Patel, Dr. Wright, and our own Dr. Deer.
Well, thank you, Dawood. And so I'll just start out by saying that, you know, I really look forward to this discussion. Certainly RF has really changed and been, as Stan Golovac just pointed out, has been really becoming a more critical part of many of our practices, because we're seeing such good long-term outcomes. And I think our goal now is to make it even better, to continue to focus on efficacy and safety with RF, and to really think that, can we get better at solutions? Can we get better at selection? So next slide, please. So really where it lies in our practice is really going to be more important, I think, as we try to think of ourselves in ways to make that process that so many patients benefit from today benefit even a greater percentage. With that, I'll turn over to my colleague, Dr. Sashi Patel. Sashi.
Thank you, Dr. Deer. Hi, everyone. I'm going to start us off by talking about the technicality and the procedural overview of RFA. Next slide, please. Radiofrequency was first performed in the 1950s, but the techniques and equipment have come a very long way since then. Often when we think about radiofrequency energy, we think of two types of treatments. One is radiofrequency neurotomy, which applies continuous RF currents to produce heat at the level of the nerves or tissue to allow for neuroablation. And the second is pulsed radiofrequency, which creates heat at the level of the nerves or tissue, but at a much lower temperature of about 42 degrees Celsius, which is believed to provide energy sufficient to modulate the electric field, but insufficient to cause tissue neuroablation. Next slide, please. As far as the RF circuit itself goes, as many of you know, this is a pretty simple illustration of how RF energy flows from a specialized generator, such as the Abbott's Neurotherm machine, through an electric electrode connected carefully to a precisely placed needle by usually a pain specialist, directed to a very painful nerve where the RF energy is activated. And this depiction, what it's trying to show is that when RF energy is activated at the level of the tissue, there's conductive molecules that vibrate, and this vibration itself is what's causing friction and resulting in heat that alters the tissue. It's also this heat that's recorded at the thermocouple at the tip of the electrode that the machine reads. The RF waves, as we know, then flow through the tissue and return back to the generator through the grounding pad. Next slide, please. So Abbott's this picture depicts Abbott's radio frequency therapy system. This is the Neurotherm 2000 machine. Next slide, please. Abbott has a great selection of probes and needles that work with the Neurotherm machine. Next slide, please. Its most unique is the Simplicity probe, which has an ergonomic handle designed to allow for maneuverability to navigate ligaments around the SI joint. It has a 3-electrode configuration that creates a single large lesion for SI joint ablations. Next slide, please. Abbott also has a full portfolio of needle gauges, variability in active tip lengths and needle lengths for a variety of pain-related procedures. Next slide, please. And this kind of draws us to the clinical uses of RF. I mean, a majority of us use it for mostly spinal-related spondylosis and facetogenic pain, but we're starting to see an evolution in this specialty in our field, in that we're starting to target more joints. And I think in the near future, with the basivertebral nerve research, we're going to see more RF treatments for vertebrogenic pain, hopefully a lot of facial pain, and more elaboration in joint pain. All right, next slide, please. With that, I hand it off to Dr. Wright, who's going to talk to you about facet joint radiofrequency ablation. Thank you.
Rob, you're on mute. You're on mute, sir.
There we go. Is that better?
Yes, sir. We got you.
Fantastic. It's good to be here. Let's jump into radio frequency facet joint. So arguably the most common etiology of spinal pain seen by practitioners in pain clinics is pain arising from the lumbar zygapophyseal joints. We know that at least 50% of the time in the literature and in my experience, axial neck and thoracic pain arises from the zygapophyseal joints, and somewhere between 15 and 40% of the time, axial pain in the low back is mediated by the zygapophyseal joints, with prevalence increasing with age. In fact, the most common procedure performed in many pain clinics is radiofrequency medial branch neurotomy of the lumbar, cervical, and thoracic joint innervation in descending order. We know that at all levels, the joint is served by dual innervation. And we also know that radiofrequency neurotomy can provide meaningful and durable relief if the right patient is selected and the right size lesion is made in the right place. That requires controlled medial branch blocks or a single medial branch block with a very high threshold for pain relief to confirm the diagnosis. It requires that the technique is rigorous and the active tip of the electrode or the cannula is placed parallel and adjacent to the medial branch nerve, and that a sufficiently large lesion is made to cover anatomic variability and also to increase the duration of relief. So recent and compelling data comes to you from the Southern Hemisphere, where I'm at this morning, in New Zealand from McVicker and their publication in Pain Medicine in 2019, showing that a majority of patients in their very rigorous study were able to completely restore activities of daily living, including return to work if they were off work, and stop all other medical treatments, including medications, for over a year, in fact, 15 months following treatment and repeat radiofrequency neurotomy using their selection criterion technique was equally effective at prolonging the relief and up to 3 years at follow-up. Next slide. Next slide. So this slide is showing an oblique imaging of the lumbar spine and highlights location of the medial branch there in the sulcus between the superior articular process and the transverse process. From this oblique rotation, the beam should be caudally declined to elongate the superior articular process and show what's called a pillar view. This sets up the trajectory for the cannula to have the active tip parallel and adjacent to the medial branch as it courses along the base of the sulcus, again, before it enters the mammalo-accessory ligament, and as defined by the cephalic juncture of the superior articular process and transverse process. Next slide. So here on the right, you'll see an image of the oblique rotation now combined with approximately 20 degrees of caudal decline, demonstrating the elongate superior articular process and showing the active tip that's distal to the bead, approximating the course of the medial branch. If we look to the left, the lateral image shows the steep angle required to achieve ideal placement relative to the medial branch. On the lateral, and this is something that's been reported and is in the SIS guidelines, but it's probably not well known, the angle of the cannula relative to the segmental superior vertebral end plate should be at least 45 degrees. This is just another way to document the critical parallel adjacent approximation of the medial branch. Now in this position, 2 to 3 lesions should be made with a larger gauge cannula, and by that I mean a minimum of 18 gauge, preferably 16 gauge, or potentially fewer lesions if you're using a technology that's been demonstrated to produce an enlarged lesion, such as the accuracy that we just heard about, an internally cooled or a time construct. Next slide. So we're going to move to an extraspinal target. Next slide. So symptomatic osteoarthritis of the knee unresponsive to conservative therapies such as physiotherapy, weight loss, or intra-articular injection with corticosteroid or viscous supplement is a very common source of disability. Hidari et al. In 2011 reported that 10% of the population in the US over 55 years of age were severely disabled with knee pain. I think it's also important to note that a significant number of patients will continue to have pain after surgical intervention. And in fact, I point you to Beswick's systematic review published in British Medical Journal in 2012, looking at outcomes after joint arthroplasty. That study informed us that significant pain persists post-arthroplasty in up to 40% of patients. So even post-operatively, we have a problem with pain and disability arising from the knee. We know that radiofrequency ablation of the genicular nerves is gaining recognition as a tool for treating knee pain unresponsive to more conservative therapies. Next slide. In 2011, Choi published a seminal study on using RF to relieve knee pain associated with symptomatic osteoarthritis. He targeted the superior lateral genicular nerve, the superior medial genicular nerve, and the inferior medial genicular nerve. Their double-blind randomized controlled trial demonstrated highly significant pain relief out to 3 months post-treatment, and subsequent publications have replicated their results. Davis et al. Subsequently published their prospective randomized multi-center controlled trial, crossover trial, looking at intra-articular corticosteroid versus genicular RFA in regional anesthesia and pain medicine in 2019, again, replicating the excellent results from Choi. Dr. Desai, one of the authors, in fact, on this panel, and perhaps can comment on this later. So the conventional targets described are, as per Choi, the superior lateral genicular nerve, superior medial genicular nerve, and the inferior medial genicular nerve. I'd note that new techniques and targets driven by neuroanatomical knowledge are being described, including targeting the vastus medialis intermedius, as well as the infrapatellar branch of the saphenous nerve. And in fact, just earlier this month, Dr. Quinn Tate from the University of Utah presented his abstract at the recent Spine Intervention Society annual meeting, reporting a successful pilot study on RF ablation for knee pain, including the distal afferent sensory branches of the vastus medialis intermedius, the vastus medialis lateralis, and the vastus medialis medialis. So in this slide on the right, the vascular anatomy in the target area is detailed. Some studies have advocated the use of adjunctive ultrasound imaging to avoid vascular injury during genicular RFA. However, I don't want to note that only one knee hematoma has been reported in the literature, only one vascular injury has been reported in the literature as of May 2019, and it did resolve uneventfully with conservative treatment only. Next slide. So moving on to the sacroiliac joint. The sacroiliac joint, next slide, is a well-acknowledged pain generator and likely source of low back and buttock pain when the index pain is below L5 and frequently when associated with specific sacral sulcus tenderness, or Fortin's finger test, if you will. The prevalence is considered to be in general 15%, increasing to over 30% in the setting of prior lumbar fusion at any level. Confirmation of the diagnosis requires, at a minimum, a well-documented intra-articular injection of anesthetic, providing a high degree of index pain relief. I use 80% as a cutoff. Repeat and confirmatory injections, of course, will decrease the false positive rate. And lateral branch blocks have been discussed and described, and they seem pragmatically useful, but as of yet have not shown to be superior to intra-articular injection for selecting patients to undergo radiofrequency neurotomy. So the big challenge, if we go to the next slide, in treating the SI joint is the highly variable neuroanatomy. So the best in current thinking is that nociception from the sacroiliac joint is carried primarily by the S1, S2, and to a lesser extent the S3 lateral branches, with possible contribution from the L5 dorsal ramus and L4 medial branch. We know the lateral branch nerves are highly variable in their craniocaudal location relative to the posterior sacral foraminal apertures where they enter. And the nerves can be either on the sacral table or they can float up to 10 millimeters off the sacral table. So again, the SI, the nociceptive pathways carrying pain from the sacroiliac joint are highly variable in their location. Denervating the SI joint requires placing a trough of ablated tissue lateral to the posterior foraminal sacral aperture at S1, S2, and S3, potentially L5, of sufficient size and volume to cover the anatomic variation and provide durable results. Next slide. So reported techniques include making multiple lesions with conventional cannula, typically in a bipolar construct, to treat a strip or trough of ablation immediately lateral to the S1 to 3 posterior foraminal sacral aperture, or alternatively clustering the lesions in a clock face around the individual sacral apertures using either conventional cannula in bipolar mode or more effectively using internally cooled RF electrodes to create larger volume lesions. Again, I'm very interested by what was presented just earlier by Dr. Golovac with regards to some new ideas around very simply and elegantly enlarging the size of a lesion. Slide. I'm also very interested in an alternative and well-conceived approach involving the Simplicity wand or RF catheter to create a continuous strip lesion via a single insertion point. Once placed along the dorsum of the sacrum, lateral to the S1 to 3 posterior foraminal sacral aperture, and in proximity to the dorsal SI joint line, the lesion will involve a sequence of monopolar and bipolar activation, resulting in a 10 to 12 millimeter cylinder of ablation positioned ideally to interrupt nociception from the SI joint. So the primary challenge in this technique is to ensure the catheter is placed along the dorsum of the SIJ and not floating off joint. Next slide. Here we see a representative AP image. I unfortunately don't have the lateral image to show the position proximate to the dorsal SI joint. But again, as long as it curves along the joint and doesn't float off in the tissue, then it's in satisfactory location. I can also share personal communication from Dr. Peter Georgius from Queensland, Australia, who's a very active and experienced practitioner. He's treated over 300 patients since 2016 with highly statistically significant, robust, and durable results at 6 and 12 months. Again, I can't comment further, and I hope these results will be published in the near future. Thank you.
Well,
Jason Brooks, take it
thank
over now,
you.
Jason.
Hey, there we are. How are you guys? Well, firstly, I just wanted to say that I'm honored to participate with my esteemed colleagues regarding radiofrequency ablation. And, you know, since the time that I've been in interventional pain, there's been a lot of exciting things that we're allowed and able to do for our patients. And I think patient accessibility is really important. And radiofrequency, certainly I can speak of on behalf of my patients that I saw today, really appreciate the opportunity to have radiofrequency as a treatment option. And it's interesting when we think about the interventions that we do. I've had a lot of patients that have migrated somewhat away from larger surgeries with an interest in trying to do something more minimally invasive, appreciating this COVID-19 pandemic, procedure room as quickly and as safely as we can. And one of those things that have really enduring data, certainly a lot of anecdotal data, is radiofrequency ablation. And as you've heard from Dr. Golovac and Dr. Wright and Dr. Patel, this is a therapy that's been grounded in evidence, but I think there is always room for improvement. And interestingly, when we look at the foundation of radiofrequency ablation, there is some work that does need to be done. And we're going to go over some slides looking at the utilization of radiofrequency, along with a negative study on the benefit of radiofrequency ablation, which is the MINT study, which was a Netherlands study. And then I think we're going to highlight a little bit about some of the challenges associated with current applications of radiofrequency treatment, and then we'll pass it over to Dr. Deer to talk a little bit about evidence synthesis. So next slide, please. So as we have approached the chronic pain patient, there are a variety of different things that we need to keep in mind, and certainly evidence is one of them. And when we look at Health and Human Services impact and recommendations on how to manage folks with chronic pain, there's really been a focus moving away from opioid-based therapy. And I have a practice in California, and even our workman's comp here in California, which is traditionally pretty challenging, does approve radiofrequency ablation. But what's interesting is when you look at the data on approval, it's very easy to get it approved, more so in the lumbar spine, and then secondarily in the cervical spine, and then it's much more challenging in the thoracic spine and the sacrum. And a lot of that has to do with the quality of evidence that we have, and also insurance carriers paying attention to the evidence that we've described. This was an investigation looking at Medicare utilization on radiofrequency, and largely what this shows is that as there's been an interest to mitigate opioid effects, there is an interest in using interventional techniques, and certainly radiofrequency is one of those things. I'd say probably 30 to 40% of the interventions that I do on a given day either are doing radiofrequency or preparing to do radiofrequency with a medial branch block. And essentially this was a healthcare utilization investigation looking at radiofrequency, and one can see that there's been an increase in utilization of radiofrequency and medial branch block techniques and intra-articular injection. If we move on to the next slide, this graph is, I think the graph that we need to keep in mind is that our utilization goes up because we want to try to avoid potentially harmful and life-ending therapies like systemic opiate-based therapy. We're going to come under more scrutiny, and we need to really have a compounded evidence to support the use of radiofrequency. As you all are aware, Medicare has made it a mandate for people to have pre-authorization for spinal cord stimulation. And obviously that's going to extend to some of the other interventions that we do. And I think having a robust evidence that is available, I think is really critical. So as healthcare utilization goes up, certainly around any procedure, there's going to be scrutiny, there's going to be an audit, and we need to be careful in how we manage that. If we move on to the next slide. This was the infamous MINT study. This was a study looking at radiofrequency ablation paired with a standard exercise program versus just conservative medical management on its own. And what this study resulted in was the conclusion that radiofrequency was not supported in treating chronic low back pain. If we move on to the next slide, we can see a little of the architecture and how they developed these. There was a large fall-off rate associated with the potential participants and those that actually participated in the study. And this was the Netherlands study that suggested that radiofrequency was unhelpful. And there are flaws associated with it, and I want to highlight that. I do applaud the investigators for trying to take a deep dive into the investigation, but I think what this really highlighted was the importance of technique. We've had experts on the panel today with Dr. Wright and Dr. Patel going over appropriate technique with needle placement, certainly with the way that the needle is placed along the median branch. I think it's really critical because we do have an oblong football-shaped lesion, and it's not something that is performed with the tip of the needle at the target. You actually have to lay the needle along the nerve in order to ablate it as completely as you can, similar to the length of lesion associated with radiofrequency. One can draw the corollary to using local anesthetic in treating nerve, and there has to be a certain length of nerve where the sodium channels are blocked in order to numb up the nerve, and radiofrequency follows that same strategy from an RF heating technique that Dr. Patel described. But clearly, we all have anecdotal evidence that this works, and I know Dr. Deere is going to go through some of the evidence that we do have, but I think this really does highlight the challenge associated with proper technique. And if we move on to the next slide, I think we have to be careful with our approaches. When we look at the things that we have in the pain physician armamentarium, we want to make sure that we do things supportively. And I just saw a patient earlier today that I did a radiofrequency of their low back almost a year and a half ago with continued benefit. So I think we all have those anecdotal successes that it works. And I think we need to design studies to make sure that we give the technique the best chance for success, knowing that it does work when executed the right way. And again, the real, I think, driving point associated with this is that you need to be careful not only about the patients that you select for, and Dr. Cohen's done a lot of work looking at radiofrequency by itself versus one diagnostic injection versus two, and the benefits associated with that. But I think also really just highlighting technique. I've said that a few times, and I want to hammer that home, that if we don't do things the right way, and if we don't select for patients the right way for therapies fail. And so we want to make sure that we give patients the best chance of success. Next slide, please. So I'm going to pass it over to Dr. Deere to take us home with some of the issues associated with radiofrequency and a robust evidence review.
Thanks, Jason. As always, you did a phenomenal job. I just have 2 slides, so this will be very quick, and then I'll bring back my other colleagues for about 5 minutes of discussion before we go on to the final shark tanks for the last half hour and finish on time at the top of the hour. This paper, many of you may have read, Steve Cohen, who I think has done amazingly fabulous work at our colleagues up there at Johns Hopkins University, and many other folks whose names you recognize here, got together with multi-specialties and multiple subspecialty groups to look at, could we create a consensus on facet disease for the lumbar spine? And so I encourage you to read this article. It's quite long, so I'm just going to show you one slide that Samar Naru's put together, and actually he tweeted, but he made this slide. Next slide, please. He made this slide that really summarized some of our evidence. So here you can see it. Grade in the grading process is described in the article quite well, but grade B means moderate level of certainty. So it seems to be, this is all based on literature, and then we made a consensus when there wasn't full literature for recommendations. Greater than 50% pain relief before medial branch block before ablation. So you see some entrants saying 80%, 70%, but the literature would suggest that you need at least 50% or more reduction in pain from a well-controlled medial branch block. Secondly, you can continue anticoagulation in most patients before a facet or an RFA. And that's really an issue. I had a patient today who'd had a stent and he couldn't come off his anticoagulants, and that seems to be fine based on the literature, a lot of cases and reports out there. And certainly you can repeat it twice a year pretty safely in people for a long-term care plan if it's successful. So that seems to be well supported in the literature without any increased risk of complications. Sedation should not be routinely used for medial branch blocks because you lose that first half hour or so from the block. But in some cases where someone has severe anxiety from a needle, you may have no choice. And in those cases, you may want to adjust your pain diary because of that. So, but in cases where you don't have to use sedation, we'd recommend you not. And then you see the low level of certainty. And I'll only cover a few of these next few things in the interest of time, but certainly there's a low level of certainty really that certainly the parallel approach for the electrode is really better. Americans have said that when they look at the MINT study that Jason just presented, but it's really not been proven in any comparative study. So we need to look closer at that. We also talk about, and this question was asked earlier to Dr. Golovac, do we do motor stimulation or do we look at safety and efficacy? And I do motor testing on every single patient, but the level of certainty is low. It's present, but it's low. But I still, if for our fellows and residents watching this, I still recommend that you do motor testing, despite the evidence being moderate to low here. Grade C, which means low to moderate level of certainty, a single block actually may be enough to predict. And certainly the more blocks you do, you may have better predictability. But based on the information that we could find in the literature and the consensus of the group, it certainly might be reasonable to do a single block before ablation. And that may have to be shown in studies to get us to the point where, you know, certainly people do well with one block instead of two. But in some patients, it may be really hard on them to travel. It may be hard on them because of their health to have two diagnostic blocks. And we're not sure that one wouldn't be adequate in most people for that decision making. So again, as you read the article, we explain that in much greater detail. The last section means low level of certainty. We talked a lot about the volume that local you should use. That's never been really proven in studies. We talked about 3 months of conservative care before facet joint interventions. That's never really been proven in studies. In fact, if you think about it, you may lose 12 weeks where people are non-functional and they may do worse. This other issue came up early in our discussion. Larger lesions have never been proven to have benefit over smaller lesions. That's why studies are needed in the lumbar spine. And then the fact that sensory stimulation has any benefit before single lesion has never been shown. I always put some steroid in at the end of an ablation to prevent neuritis, but that's again not well supported in the literature. There's low level of certainty that really works, and certainly there appears to be really no evidence of interference with implanted devices. I may have exhausted you with this slide. It's a lot to really take in. I think Abbott will make these slides available as part of a video of this presentation, which they'll share. Plus, the members of ASPN can go back on the website and view all this again. With that, I'll bring my colleagues out. We have about 4 minutes of questions, so I have a question for each of my colleagues to finish this section. Then Dawood will join us. So if you could come back and join me, Dr. Patel, Dr. Wright, Dr. Pope. And I'll start off with the first question for Dr. Pope. Jason, you know, every American I know has criticized the MINT study. It was poorly done, I would say. And my colleagues in Europe who are friends of mine who did that study, I've told them that. Give me one thing you would do differently in that study and why you think it may change the outcome.
Well, thanks, Tim. I think, as I harped on during my portion of the presentation, I think technique is critical. And so making sure that you really lay the needle along the nerve where that SAP and transverse process is important. And that was not done. So validating needle position either in, well, definitely in 2 views, I think is the appropriate pathway to make sure that you're really close to the nerve. And certainly, as we've described with the level of evidence, stimulating the nerve either with sensory or motor, you know, as the evidence is equivocal. I'm like you in that I still do motor testing to make sure that I'm not near the nerve. I'm going to do a double negative here, not near the nerve that I don't want to burn. So it's so I do think that it's critical that we really harp on technique when we're investigating an interventional treatment path.
You've left West Virginia, but your grammar remains here with me, Ablation. So I love that.
And I got the beer.
And you get the beer. Dr. Patel, question for you. I had a medical student today, and I had a couple of beautiful x-rays. Like Jason points out, AP, lateral, and Scotty dog views were just beautiful. And I actually printed those out to show him exactly where the needle goes. What do you do in those people with difficult anatomy where you can't quite get the perfect view on all three of those views? What's most important?
Oh, testing, I think, for me ends up being most important. But I take multiple shots. So I start with the AP, go to lateral, AP, go to lateral, and oblique as best as I can to try to find that Scotty dog. If I'm still hesitant, I think the sensory and the motor testing do provide some feedback as to if you're close enough to the nerve, especially if you get during motor testing, if you get activation of the rectus spinae muscle, you know that you're relatively close to the nerve that you're trying to seek.
Yeah, I love your answer because I don't think motor testing has great safety value anymore because I think we're pretty much away from the motor nerve or would be worried. But I love when I see the multifidus moving. To me, that's a really good indication. So that's a phenomenal answer. Dr. Wright, you get the last question. So Rob, simplicity. You showed it in your slide. Our practice used it years ago. We're just now bringing that back to our practice. I'm actually bringing that back because I've heard some good things from colleagues like yourself. Give us one pearl about using that probe that makes it both better and safer for our patients.
Yeah, I mean, there is a pretty steep initial curve in terms of getting the technique down. And I think if there was one pearl, I would recommend that you place initially a finer needle along the trajectory that you propose to place the simplicity. So start there, just lateral to the S4 foramen would be your skin entry site. Then you can take just a 25 or 23 gauge regular 3.5-inch spinal needle and then touch down onto bone and anesthetize and kind of get your proprioception in place and get that track anesthetized down. And that's going to be very valuable in terms of subsequently placing the active RF cannula along that same course. So one pearl is use a finer needle.
No, I think that's a great pearl because, again, I think that's the question. If you don't get proper local anesthetic, it's going to be very difficult. So with that, I'll ask each of you to give me a 30-second pearl for RF before we close the session. So Dr. Patel, I'll start with you. Give me a 30-second pearl for our younger viewers out there.
Use your imaging as guidance and continue to do what the safer thing is, which is using sensory testing and motor testing until you feel confident.
Very good. I disagree with the sensory part, but I think it's good pearl. Dr. Wright, your thoughts?
Go big or go home.
For the fellows and residents, that's great advice right there. Dr. Pope, you get the last comment. I may disagree with you as well, just warning you.
Local. So I do all these under local anesthesia only. I do not use sedation. So if you do the appropriate local anesthetic skin wheel, radio frequency is not a problem at all.
Great job, all three of you. Thank you so much. Have a great what's left of your nights, and we'll see you soon.
Thanks,
Bye-bye.
guys.
Dawood, we're on to the think tank, which will be the last 29 minutes or so of our show. So
yeah.
I'm Dr. Tim Deere.
And I'm Dr. Dawood Sayed. And we're excited to be hosting the American Society of Pain and Neuroscience's annual virtual conference, broadcast live from Nashville, Tennessee on September 18th through the 20th.
As we come together in Nashville, we'll be addressing several issues that are important to our members and to future members. Things such as minimally invasive procedures for the spine, proper methods of patient selection for interventional pain techniques, and most importantly, safety and efficacy of patients going forward as we progress the field to make things less invasive, more
go as smoothly as we did earlier, so you'll be seeing that online this week. So Dawood talked about the think tank.
Yeah, so again,
Chakravarthy, Krishnan's going to join us up there.
Krishnan can jump on. Mr. Wonderful, as we're going to refer to him today. So as our Shark Tank sessions last week, we had really a couple really cool, innovative companies, and we're going to continue that today. Our Shark Tank session number 2 is going to kick off with, I believe, Curogram.
I think we were. Doctor.com is first.
Oh, sorry, doctor.com. Please take it away, doctor.com team.
Hello, everyone. How are you? Thank you,
Hello.
Dr. Deere. Thank you, Dr. Sayed. Thank you, Dr. Chakravarthy, for having us. We're really excited to be part of the Shark Tank today. And I know there's a lot going on with this pandemic. There were a lot of topics and high-tech features we could be discussing, but I felt that it was really important to go over how to build patient rapport to collect high-quality procedure-specific reviews. So I know we talk a lot about reviews, and I know that most people understand that they're important. However, I think it's pretty underrated, and a lot of the processes behind making this work effectively fall by the wayside because we get so busy and inundated with everything else going on in the practice. So today we're gonna go over some of our best kept secrets about collecting reviews and the different ways that you can scale this out to build out a thriving pain management practice. My name is Jessica Nikchi. I'm the general manager of Doctor.com, and I run the emerging market solutions side of our business. And I have today with me Dr. Nicholas Giordano, an interventional pain management PMR physician that's going to go over some great best practices in terms of collecting reviews. So first I want to go over our agenda. So we're going to discuss today why reviews are important, when and how to ask for the review, and I'm going to go over some best practices in my playbook, but then also go over the way Dr. Giordano has been able to effectively implement some of these review strategies, and he makes it seem so easy. So we're going to go over that. And then hopefully if we have time, we'll talk about how you can leverage telemedicine for reviews, and then go over any Q&A. So let's talk about why reviews are important. So first things first, the modern patient journey has changed tremendously. Patient behavior has changed, right? And then on the next slide, 88% of patients will read reviews about a provider even after they've been referred. So like 20 years ago, when you'd get a referral, the patient would pick up their house phone, they'd call you, they'd make an appointment. Now they're taking, their computer, cell phone out of their pocket, and they're going to research you. So referrals are just a way to research physicians today. And not only do you have to worry about getting new patients, but you need to worry about ensuring that your referrals actually convert as well. And then secondly, 56% of patients will consult 3 different online sources. So in order to build a sustainable foundation for your online presence, you need to look good on a multitude of sites. Google is just a search engine, it's not a website, and Google deems all of these healthcare sites super credible. So when people ask, where should I send my patients to leave reviews? Is it Healthgrades? Is it Google? The answer is that you need multiple review sites because patients will go there regardless, and you want to maximize your potential, and you want every piece of your, reputation pie, if you will. And then on the next slide, we'll talk about how there are 2 top barriers for patients that are considering a procedure. We actually conducted this survey on how patients are shopping for orthobiologic treatments. As we know, a lot of our pain management physicians are including some of these lesser known therapies. And the #1 barrier to proof was lack of social proof. And what's interesting is Dr. Sayed, I was listening to one of your webinars maybe 5 or 6 webinars ago, and you were talking about the technological boom that we're seeing in pain management, and it's so exciting, but we have such amazing treatments, right, that people haven't heard of. And although we might have that anecdotal evidence, maybe we're doing patient registry outcomes, patients aren't reading that. And it's kind of like what the millennials say, if it's not online, if you don't post it, it never really happened. So how are we going to convey the success rate of these treatments, allow other patients to learn more about what to expect by some of those patient testimonials? Because what we're finding, they're really your best form of marketing. And then second was obviously cost, which anything that costs a lot, people are going to do their due diligence even further. So it's just more of a reason why not only do you need procedure-specific reviews, but recency and volume play a huge factor in that. And then on our next slide, so let's talk about when and how to ask for a review, because this is what I think gets the most awkward, right? As a physician, you might have patients who love you. Maybe some of them don't, but it gets a little awkward because you don't want to feel like you're soliciting, and you want it to be a genuine moment. So what we say is, you got to look for that magic moment with your patient. I find that a lot of offices want that silver bullet approach where they're like, hey, Jess, can't we just send an email blast of text messages to leave a review request to our patients? Isn't there a way to automate this process where we can just send review requests left and right to people to increase our conversion? And the answer is, if you just randomly send people a text or an email blast for that matter, you get a less than 10% conversion. So I know that's not the answer that your staff wants to hear, because they want obviously less work to do while they're super busy and dealing with patients. However, if you have a dialogue with that patient and you ask them about their experience, ask them about their day, they'll be 80% more likely to leave that review. And you can alleviate some of that pressure for you and your staff of feeling like, hey, I need to ask every single patient that walks in through the door. No, it's about, ask 3, maybe 5 patients a week that are happy, that love you, that might be able to provide feedback that would help other patients like them. And it's a great moment to empower that patient to tell their story about what you've been able to help them achieve. On the next slide, we'll talk about how to collect quality reviews. So we've kind of created a playbook here. So first things first, your review needs to come from a credible source. Google, Healthgrades, Vitals, these are all sites deemed credible by search engines like Google and Bing. So if you say, hey, I'm using an EMR system and my reviews go to patientconnect.com, like, won't my patients see those reviews there? Nobody knows what Patient Connect is and they don't trust it. So if you're going to spend time getting reviews, you want to make sure that they're being posted on sites that are relevant to patient search and places that people are going to go. Another thing is that I don't know if anyone's noticed, but in my example here, if you look at my client, Dr. John East, I actually brought him on a 1.5 years ago. And in January, Google started to arrange keywords in your reviews. I don't know if anyone's noticed that, but you click onto your reviews and you go to see all. And then in this example, my client was able to get 61 reviews about pain management. As a patient, I can click on that keyword. It's going to pull up the 61 reviews. Luckily, he has 5-star ratings for all of them, but that's great. If I go to rhizotomy, it's going to pull up all of the reviews about rhizotomy. And in our curriculum today and over the past week, I've heard amazing stories about new advances and different things that we're doing, but it's really important that we take that and now convey it digitally so that we can make our digital footprint online as well. These keywords are super important. If you are implementing orthobiologics, you know that there is a ban on advertising some of these treatments, but reviews are fair game. So this is huge. And then in the next slide, it's about asking the right questions. So the structure that we like to use is ask the patient what the issue is that they came in for. What treatment did they receive? What was the result of their treatment? This dialogue and structure is great for you and your staff to utilize so you can have open-ended questions with that patient, build rapport with them, really understand where they're coming from so that when you ask for the review, they're that much more excited to share that feedback and get specific. I even have some of my physicians and practices write down the name of the treatment, write down the device name as well. Those keywords are going to be imperative for your short and long-term bottom line. And then on the next slide, I'm excited to go over what Dr. Giordano's experience has been and the way he's been able to sort of combat some of the effects of the pandemic right now and what he's been able to do to build out his thriving pain management practice. Dr. Giordano?
Well, thanks for having me, everyone. It's great to see everybody again. It's been a great web series so far, and it's really an honor just to be a part of it. So I'm here today to speak a little bit about how to incorporate collecting online reviews into your practice. I actually met Jessica about 6 months ago at World Institute of Pain, and she was extremely quick to point out how weak my online presence was at the time. And prior to that conversation, I gave very little thought into what my online reviews actually were. I'm always pretty active with social media, so I kind of thought that was enough, and now I realize that's very wrong. I actually came to realize that what your online reviews are they're essentially your CV, but for your patients. You know, as doctors, we work very hard over the years to go to the best medical schools, do research, get on stage, volunteer just for that piece of paper to make that good first impression. Unfortunately, our patients aren't looking at that piece of paper. You're lucky if they get that far into your website. So having said that, I want my online reviews to be as good as possible to gain their trust before meeting me. And that's essentially what they're going to do. They're going to judge you based on your reviews before they even walk in the door. So after realizing it was weak, I made a conscious decision to change my practice. And thanks to Jessica, she actually gave me some awareness into these SEO specific buzzwords. And I realized that even though a 5-star review is great, it's even better if they can kind of use the words you need them to use. And if there's one consistent thing that I've realized over the past 6 months that I've been doing this for, is that patients are excited and they want to help you. If you do the right thing for a patient, they're excited to reciprocate in some way. And, you know, we can go down a rabbit hole about what that means to do the right thing. Like, are you a good doctor? Are you doing the right procedures? Are they up to date? Are you getting good results? But let's focus today on really how to ask the question. And I kind of giggled a little bit before when Jessica put that slide up about the magic moment. I don't really think there is per se a magic moment, but I think you need to be aware of the buzzwords and the conversation going on in the room. This way, you know, you can hone in on when it's a good time to ask further a review. And when I think it's a good idea, I stop asking direct questions, such as like, how much pain relief did you have, or how long did that relief last for? And I switch to more open-ended questions like, how did this change your life? Are you happy? What were your expectations? And then my favorite is, did you know this procedure existed before we did this for you? And you'd be surprised, a lot of patients have never heard about what we did, and the ones that have heard about it were so hesitant that they're excited to share their stories to pass it on to other patients. So that's what I like to stress. I like to tell patients how there are many people in the same position that you are just a few months ago. And, you know, if you put this out there, you never know who's going to see it. And based on that, you know, you can be helping a lot of people as well. So when I ask for that review, I will ask for a few keywords. You know, I'll ask them just like, maybe you can talk about stenosis, or tell them what we did for you. Tell them about that stimulator trial that we did. And it may just be anecdotal data, but from what I'm realizing, the patients who I'm doing the bigger procedures on, they're a lot faster to respond to this conversation, and they're a lot quicker to get me those reviews when I ask for them. They want to share it for you. And the other thing I just want to make a point of, you know, a few times during this conference, it came up that how can we make what we do more mainstream? Like, how could you popularize what we do? And, you know, this should definitely be a part of the conversation. If there's over 600 people on these webcasts every night, if we all go out of our way and get 1 or 2 reviews that say something like stim trial, that's how you go about making things more mainstream. And for some reason, these days, people are more skeptical of figures of authority, including doctors. So like, it's good to have that come from another patient. And it's something I'm going to continue to like put forward in my practice going forward.
Kudos. Thank you, Dr. Giordano. And for the record, he collected 32 reviews in the last 6 months on his health grades profile. And we make jokes that they sound fake because they're actually amazing. But he has sent me screenshots of the patients that shared some of his feedback as well. So it's pretty cool. He was even able to get some of the devices. Abbott was mentioned in some of the reviews. So it's important that we work together to really get that content out there. So thank you so much, Dr. Giordano. That was awesome.
Thanks for having me.
Thank you. I'd love to go over any Q&A on any questions that you have, or anyone out there.
I can ask the first one, maybe.
Please, Krish.
So, you know, we talk about these online reviews, and most times they're very positive. What suggestion do you have if you get a negative review? I mean, I think that's one of the challenges sometimes with getting all this stuff put on there. What would you suggest? And especially in the social media world where everything's accessible, we always talk about what to put on and what kind of content we should put up there.
Absolutely. Oh, go ahead, Dr. Jordan. I'd love for you to take that. Okay.
So the thing is that the bad reviews are going to come, and you really can't, you can't really do much about that, because in our profession, you really can't be a yes man. But what I'm realizing is, you can get ahead of them. If it's just one bad review for every 15 or 20 good reviews, then I think you're still doing a really good job. So what I've been trying to do is really drown them out, and I think that's really all we can do with the nature of our field.
And Nick, I love that. I love that answer, because I think, I think I've been very impressed by both you and Jessica tonight. So great job. Look forward to maybe having both of you later for a longer discussion. But, a lot of times I have people tell me they got a negative review, and a lot of people say don't read your reviews because of that, because it bothers you. But I think you're right. I think I like your philosophy that Jessica's taught you and that you're using, and that is, you want to make sure you capitalize on the positive, and I think people will capitalize on that. So, Dawood, any final thoughts before we move on to the next session?
Yeah, I'd like Jessica just to give us her closing thoughts on why doctor.com is the way to go for us. We're going to have hundreds of our Aspen members watching this. So why should they go with your platform versus some of the other competitors?
Absolutely, that's an amazing question. So as we were talking about getting reviews on a multitude of sites, we're the only company that has a one-to-many platform where we partner up with Google, strategically Healthgrades, Vitals, WebMD, and we allow you to collect one review at the office that we post onto 10 sites. So if you look at that one client example that I used, Dr. John East, he has over 300 reviews now that he collected through our device that is spread out to 10 sites. So think if you get a review about kyphoplasty, 10 patients leave a review about it, that's 100 pieces of content associating you and kyphoplasty. So it's just the only one-to-many platform to get as much spreadability, making it easy, and it's super comprehensive. And it's great. It's great for your long-term and short-term practice goals, but your reviews are going to follow you at the end of the day forever throughout your career. So it's important to invest in your own name as much as you can.
That's great insight. And Nick, it's wonderful to see you again, my friend. Good job, and keep up the great work. Guys. And Jessica, great job. Thank you so much for educating us about this.
Thank you for having us.
Welcome.
Yeah,
Chris, you want to lead us into the next session?
Yeah. So interestingly, I think Curogram is going to be talking about a little bit on texting and telemedicine. So I just actually looked up a recent press release. So they acquired up to 1.8 million in funding. So this is probably interesting to see that it's up and exciting type of startup. So Michael, take it away.
Yeah, thank you everyone for inviting us today. So I'm going to be talking about texting and telemedicine today. And if you have any questions throughout the presentation, feel free to text me, actually, and I'll try to answer them at the end of the call or at the end of the presentation, or I can reply to you at a future time. But I'm the COO here, and our focus is patient communications, and we're an add-on typically to your practice management system. You can go to the next slide. So again, I'll be talking about texting, text messaging and telemedicine, and really our focus here is to make it simple for both the patients and the providers. And texting is really the cure for, what we call telephone pain. This is a pain conference, so I thought I'd make it applicable. And texting is really pain. I'm sorry, there's a typo there. That's telephone is painful for provider's office because it's old technology, it's time consuming. It interrupts workflows, and it's a source of stress for both the providers and the patients. And you can see here, patients hate the phone because they don't like dealing with your phone trees, being put on hold, playing voicemail tag with the office. It's a real pain point for everyone. And when you look at the new patient consumer and what they are looking for, NRC Health has actually did a survey and found that the #1 factor that patients value when they choose their provider is convenience. And if you go to the next slide, you'll see here that really we believe in today's market, convenience means access, and that really means text messaging first of all for access, because that's the preferred method of communication of all consumers today. And the second piece of convenience today, now in this new world of this pandemic and remote communication with patients, simple telemedicine is a really key aspect of that. with regards to texting, the reason why it's such a critical form now is that 90% of text messages are read within the first 3 minutes receiving it, versus emails are only read, 60% of which are only read within the first 24 hours. And then phone calls, less than 30% are even answered nowadays. And that's a really, those statistics are pretty telling, showing that texting is such a critical form of communication. And so what is Curogram? Well, it's the most advanced, easiest to use, HIPAA compliant, two-way texting and telemedicine platform. And to start off with the two-way texting, we have a simple web dashboard that interfaces with virtually any EMR or practice management system. We have proprietary technology that allows us to interface with any of the 700 different systems out there. You can use your computer to text patients on their phone. We can also use your existing office number, your landline, so we can make it textable. And so patients even that are familiar with your number are going to be already familiar with their text number. And then lastly, every patient has SMS on their phone. It doesn't require an app download. It's super easy. Within 24 hours, your office will be, communicating better with their patients. On the telemedicine side, this is, I'm sure, something that you've all dealt with in the past 3 to 4 months. And one thing that we found, which is super critical, one is having a telemedicine platform that doesn't require app downloads for patients. And so our system is browser-based. The patient gets an automated text message from our system, from our reminder system. So as I mentioned, we do two-way texting, but we also have many patient engagement features that are layered on top of that texting, one of them which is appointment reminders. And since we integrate with an EMR, we also know from your EMR which visit types are telemedicine and which visit types are in person, which means we can differentiate. And when it's a telemedicine visit, we just automatically include the link for the video visit. There's no extra communication, trying to email, call, or give them some Zoom link or something else to get them online. They get it automatically in their text or email or both. And then when you look at the top screen here on the top right, it's a little bit hard, I'm sure, to see, but what you see there are under visit status column. These are workflow tools, and this is really important. So this is our virtual lobby, and when people click into, or when patients come into the lobby, they start in check-in status just like they do in your physical lobby. They're checking in, and you can actually have multiple providers on the call at the same time. And so you could have your front desk staff or scheduling team check the patient in virtually just like they would in the front office. And then they can switch the workflow status to physician consult. And that'll move them down the queue. And if you're a physician, you'll see that patient show up in your view, and you click in and join the call. So we give you the workflow tools to mimic your in-person office experience online. And the providers, you can use your laptops or cell phones because we do have a provider-based app. So that's very convenient for people that, for example, today, if you want to continue your charting in your existing EMR, you're using your laptop for charting, and you can use your device as your video tool. Next slide, please. I mentioned appointment reminders. This is one of another key features on our platform. We have the most advanced, simple appointment reminders on the market. It's fully customizable by appointment type and location, so you can customize these messages on the fly. When COVID hit, a lot of our clients customized it, letting their patients know that, hey, we're not seeing patients in the office, we're shifting to telemedicine. Now that they're coming back, they're telling patients, hey, don't come into the lobby, just text us when you arrive in the parking lot. You can actually customize your reminders with prep instructions for every type of visit. So as a pain group, I'm sure you have all types of visit types. You can give a different prep instruction for everyone prior to that patient coming in. There's no character limits to our reminders, so you can say whatever you like. As I mentioned, we differentiate between in-person and telemedicine appointments. So if it's an in-person visit, you can include automatically driving directions to your office. If it's telemed, you can include your video link. And we've seen response rates of 70 to 80% on average from our client base. And so it's a very highly engaged system. And this will reduce your no-shows by 75% easily if you don't have a system in place today. Next slide. Another feature we have on the platform is smart surveys and ratings. These are, again, utilizing the texting system after every visit. And this is where I'll disagree with Dr.com a little bit. We find that you don't need to engage every patient, manually yourself as a doctor, or having your front desk staff ask every patient to leave you a review, or figure out who's happy, who's not, and then ask the happy ones to leave you a review. We automate this process completely. After every visit, we send a one-line text, how was your visit 0 to 10? And we filter the happy and unhappy patients. So we know it's an internal survey, so you know who's happy and who's not. And then if they're unhappy, we notify the office manager right away. We also have a follow-up survey that can ask the patients what they're unhappy about, so you can identify in your practice what needs fixing. And then those that are happy, you can automatically offer them a link to your Google review or health grades or vitals, whatever you'd like, although we generally recommend Google. I think if you look at the picture here, this is one of our clients. They started with 15 reviews, and in less than a year, they were over 400. And that was all through automation. None of the doctors had to engage with the patients to get those reviews. And the staff didn't have to do anything. It was all behind the scenes. And also the practice reduced their 1-star reviews because, I think somebody said they will come and there's not much you can do about it. But I actually tend to disagree, because if you know real time when that patient leaves your office that day that they're unhappy, you can contact them, solve their issue real time, and actually hopefully prevent them from going home and giving you that 1-star review. So that's our smart survey rating system. And this is a quick overview of how offices are using our platform today. They're using it to confirm appointments. Patients are using the two-way texting to book appointments via text. They're using the two-way texting to coordinate schedule changes, answering pre and post-visit questions, some through automation with the prep instructions, and some just through two-way texting. People are responding to prescription refill requests. You can send electronic patient forms, so your intake forms can be automated. You can send us your forms, your paper forms. We digitize them. We make them fillable online through your smartphone or your laptop. And then we help you get the automated 5-star reviews we mentioned, and we provide very simple telemedicine platform. Implementation is super simple. Like I mentioned, we sync with any EMR. Generally, for small, mid-sized practices, we can implement in 48 hours or less, and we train in less than 30 minutes. So you're up and running very quickly, and you can start using it right away. This one simple case study here is a multi-location client, high-volume clinic. They had a central call center with multiple local offices. They started using our reminder system and two-way texting. They received over 80% response rate on SMS. They reduced their incoming phone calls by 50% within 3 months. So it's a huge savings on their overhead and huge patient satisfaction increase because the patients didn't have to deal with the phones anymore. They reduced their no-shows by 75%, and they got over 100 5-star reviews in 6 months. So at the end of the day, our value proposition is that we increase revenue by helping reduce your no-shows, improving your online reputation. We help reduce costs by reducing your phone calls and increasing your staff productivity. We improve patient satisfaction through convenience of texting and simple telemedicine. And this is our leadership team. My partner, Shalini, was a senior engineer at Skype before this, so we've got expertise in messaging. Myself handle all the business operations. So I'm happy to answer any questions that anybody might have.
Michael, great job. Certainly, I think you had a tough spot at the end of the conference, and you did a great job keeping people interested. And certainly, I learned a lot from it myself. I think Dr. Chakravarthy has a question for you.
Sure. So Michael, one of the challenges for physicians this day and age is a little bit on over access. I think that a lot of patient expectations on responding, look at some of the My chart that Epic has built out and interfacing. How do you manage those expectations if you're now being able to access, or patients are able to access physicians through texting? Is there a point where kind of our work-life balance could be harder to balance from that perspective if they have that immediate access?
Yeah, it's a great question. So the interesting thing is what we learned is that outside of your time in the exam room, the doctors are not the ones using our system for the most part. Other than the telemedicine, the texting is really between the front office or scheduling office and the patients, because that's where the high volume of communication is happening today. And I'm sure you guys may probably prior to COVID, you noticed it more. I'm sure everyone on this call or watching this can sympathize or empathize with the craziness of phone calls, right? Just the deluge of patients calling, rescheduling, trying to change, trying to fix, answer questions. And so what we've really done is we've taken all that phone call volume and we've shifted it to text messaging. And so it's not really, we're not seeing that the patients are now, dumping on the doctors all of a sudden. They're just now a lot happier because they can text the front desk instead of calling them. That's really what's happening.
One last question. This will be, I promise I won't mention the last question of the whole night, but I think it's important. So do you have any training for the staff, Michael, when they're texting? Obviously medical legally, I do a lot of malpractice defense work, occasionally a plaintiff work, but mostly defense. But sometimes there's something in the chart, an email or a text that you say, well, that was a very unfortunate text or unfortunate email, which maybe led to some issues. Do you have medical legal advice in texting with your company for the staff?
Yeah, so the two things. One's I didn't cover it in this call because it's a pretty short call, but we also have encrypted HIPAA secure messaging as well. So if you want to communicate PHI via the app, it's a very simple click of a button. Before you send a message, you just click, hey, encrypt this, and then that sends it and still gives the patient an SMS notification, but it puts them into our free encrypted patient app, which is very easy to download and use. And so that's one way. If you do want to communicate PHI, you can still do it through the same dashboard. But on the flip side, your question around medical legal, what a lot of our clients like is that, when their front desk staff or their back office staff are using our system to text the patients, it's fully auditable. They know what the staff are saying to the patients, and so they actually have a view into what's happening in their practice. On the phone, there's no good record. So the patients are, calling saying, hey, I told this, or your front desk told me, or your PA told me this, or your MA told me this. It's a he said, she said. But on text, it's actually very clear, and that still goes back to you training your staff to do things properly, but it actually makes it easier from their perspective because they're protected. If they're doing their job right, if they're doing their job wrong, it doesn't matter what communication medium they're using, they're still going to get you in trouble. But if they're doing their job right and they're using texting, it's actually it's a much better audit trail for them and for you.
Well, thank you very much, Michael. As Christian kind of said, congratulations. Looks like a shark has already bitten with your recent raise. So congratulations and fantastic job.
Yeah. Thank
nice
you.
Work. Nice work, Michael. Good job.
Yeah, if I had one minute, I'll mention the one unique thing about our company is that we have the investors, a vast majority of the investors in our company are physicians and users of the product. We have over 100 different physicians invested in the company. We've actually, I think the news article you mentioned is somewhat old. We've actually raised $4 million to date, and we're continuing to raise money. We're growing exponentially fast. We had 15 people a year and a half ago. Today we have over 90 people. We just became profitable last month, and we are very active in the COVID testing space. And that's something I didn't have time to talk about on this webinar, but we're doing a lot of things in COVID testing. And one of the unique things that we're launching pretty soon is home-based home kits for COVID testing, which the application for you guys is that I've seen, with this pandemic and people not being able to come back in for elective surgeries and things like that, we're trying to create a way that's easier for them to get the testing they need to make sure that they're, have results in time before surgery or procedure or any type of thing. So that's something that may be applicable to you guys in the operations. But from an investor standpoint, if there is anybody interested in investing, we're always looking for strategic physician investors. And if that's something that anybody here is interested in, please feel free to reach out to me. My text number was, displayed earlier.
Thank you so much. Have a great week. Appreciate you, Michael.
Thank you, guys.
Dawood, you have a few announcements.
Yeah, so as we had the video play earlier, our annual meeting is going virtual. It'll be September 18th through the 20th. All the times and sessions will remain the same. Tomorrow we'll conclude our Shark Tank with not a 3-hour session. It'll be a little bit of a shorter session tomorrow, and we'll be shifting to minimally invasive spine. We'll have sessions by Boston Scientific on interspinal spacers, Vertos Medical on minimally invasive lumbar decompression, and then we'll have 2 Shark Tank sessions tomorrow as well. So thank you everyone for joining us. It was a long day, but everyone kind of stayed on and held on. So I'm assuming that the context was engaging. So thank you everyone.
Good night.
Good night.